Madam Chair, we are live on YouTube. Sorry for the delay.
All right, thank you. Good morning, everyone. This is the Public Employee Benefit Program meeting on January 23rd, 2025 at 9:04 a.m. We're conducting this meeting virtually. I would like to call the meeting to order. Would staff please call the roll?
Good morning, everyone. Starting roll call, Joy Bremer,
Present.
Michelle Kelly,
Present.
Jim Barnes,
Here.
Jennifer McClendon,
Present.
Janelle Woodward,
Present.
Betsy Strasberg,
Present.
Stacy Weeks. Okay, it appears Stacy is absent, but we do have a quorum. Please remember to state and spell your name for our transcriber before speaking. Thank you.
Okay, we will move on to agenda item number 2, public comment. Public comment will be taken during this agenda item. No action may be taken on any matter raised under this item unless the matter is included on a future agenda item as an item on which action may be taken. Public comments to the board will be taken under advisement, but will not be answered during the meeting. I'll now turn it over to IT to conduct public comment online.
One moment, Madam Chair. I got to get a slide up and do a couple of the configurations real quick. Let's see. If you would like to call in to provide public comment, please dial 669-900-6833. When prompted to provide your meeting ID, please enter 870-927-30987, then press pound. When prompted for participant ID, please press pound. Joining the Zoom meeting as an attendee is for making public comment only. If you do not wish to make a public comment, please leave the meeting so that you're not accidentally called upon. Please feel free to watch it via the YouTube live stream on the PEB YouTube channel. The link for the live stream is also located on the agenda on the PEB website. In addition to for those who have joined for public comment, your name or the last 4 digits of your phone number will be announced and you will be advised you've been unmuted. Please slowly state and spell your name for the record and then proceed with your comments. For those who are on the phone, please press *6 to unmute. Timothy Hoft, please slowly state and spell your name for the record if you wish to make public comment.
Timothy Hoft, TIMOTHYHOFT. Can you hear me?
Yes, we can. Thank you.
Okay, thanks. Forgive me, I'm quite tired this morning. The reason why I'm tired is because yesterday I had to have an infusion of Remicade for my chronic illness of Crohn's disease, which I've had for 23 years. I'm 43 years old right now. I've been working at UNLV for 13 years, and I'm a tenured professor. This medicine that I had to take yesterday, it's a life-saving drug, but it does kind of make me very, very tired for the first 24 hours. In a couple of weeks, I'm going to get a bill for this drug, and it'll say that the drug will cost $12,000. Of the $12,000, I only have a $25 copay because I'm on an HMO. I have to take this drug once every 8 weeks. So every 8 weeks, I get a bill for $12,000, in which I only pay $25. This disease will progress as I grow older, which means I'll have to take the drug every 6 weeks instead of every 8 weeks, and then eventually every 4 weeks instead of every 8 weeks. And it is a drug that my doctor has told me that I'll have to take for the rest of my life. This news that I might be thrown off of my HMO and replaced with a PPO is the worst news I have received since becoming an employee at UNLV. I'm absolutely terrified what will happen. I looked at all of the numbers. 80% coverage of this drug is not going to cut it. I'm going to go bankrupt if that happens. I'm going to have to start a GoFundMe page. I'll have to work a second job, although I don't have the energy to work a second job. There has to be a better solution than this. I don't appreciate the board treating me like I'm just a number and that you're just looking at how much money you can possibly save, because my life is at risk. And you need to figure out a better solution than removing the HMO. Thank you.
Thank you. Stephanie Goodman, can you please slowly state and spell your name for the record if we should make public comment?
Hi, my name is Stephanie Goodman, Stephanie Goodman, Goodman. I am a university regent with the Nevada System of Higher Education, and we've had several, actually multiple complaints regarding the fact that this board is contemplating eliminating the HMO and also changing the low deductible PPO to a standard PPO. You are leaving so many people in our community in dire straits if this happens. And I would just ask you to really consider the ramifications of doing something so dire. I guess, it gets old hearing about how we all, as people who represent our state, how we say that education is a priority. Not only did the state at the last session only fund our COLAs for our professors and all of our individuals that are working within NSHE at a 64% rate rather than 80% because of a clerical error. And it was an unprecedented raise. It was a 23% raise that we finally were able to give our individuals that are working at NSHE. And the problem is that they hadn't had a raise since 2008. And so I don't understand how you could now be wanting to affect, the thing that is of dire importance to them, which is their health insurance. You are putting so many people in a space where they are worried. They've been worried for months, ever since this news came out, that you were considering eliminating the HMO. The gentleman that just spoke before me, there are so many cases like this. And we really need to just say, how do we take care of the people in our state? And this is a way that we can continue to take care of the people in our state. And I would just really ask for you to consider the ramifications of this are dire. We are putting people's lives at risk. And I think it's very important for you to please, if you would, find another way to make this work so that individuals can keep their HMOs. Thank you very much.
Minnie Wood, please slowly state and spell your name for the record if you should make public comment.
Hi, my name is Minnie Wood, MINNIEWOOD, and I'm speaking on agenda item 7.1 today. I'm a faculty member at the University of Nevada, Las Vegas in the School of Nursing, and I'm also a nurse practitioner in our local community. For the past 9 years, both myself and my 2 teenage children have been covered by the PEBP HMO insurance plan. It's hard to imagine the last 2 years without the coverage that an HMO plan provides, as I battled breast cancer and will remain in treatment to prevent recurrence for the next 5 to 10 years. During this time, one of my children also had surgery and another had an urgent medical situation. With our HMO plan, our costs were both predictable and manageable. I'm commenting today to ask the board to not proceed with elimination of the HMO insurance plan, leaving people like me and my children with only a PPO option. With a PPO plan, my medical costs will be difficult to forecast, but will likely reach the out-of-pocket maximum each and every year. Having a stable HMO plan with clear and reasonable out-of-pocket costs is one of my most valued benefits as a faculty member. I fear losing it and the impact it will have on both my finances and the quality of care I receive in our community based on insurance interruption and what I can afford. I urge you to do everything in your power to keep an HMO among the health insurance options that public employees in the state of Nevada can choose from. Thank you.
Thank you. Debbie, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment.
Yes, it is Deborah, Deborah Arteaga. That's A-R-T as in Tom, E-A-G as in girl, A. Good morning, board members. I am Faculty Senate Chair of UNLV, and I am speaking on behalf of our employees. I have received dozens of calls and emails, and I have been CC'd on many written comments. I wish to speak against eliminating the HMO, EPO in the North and converting the low deductible PPO to what Siegel names PPO Option 2. I have carefully studied the report from Siegel, and today I have questions and comments. The presentation suggests that keeping the HMO EPO is not fiscally viable. At what price point does it become viable? In other words, how much would employees have to raise the premium? My colleagues have told me that an increase in premiums is preferable to losing their HMO coverage. Moreover, health insurance premiums are deductible on a pre-tax basis. Several pages present a comparison of insurance coverage. The following states are used for comparison: Alaska, Arizona, Colorado, Idaho, Montana, New Mexico, Utah, and Wyoming. It is unclear why those states in particular were chosen. For example, colleagues who have previously worked in California have told me that the health insurance there is much better. In this data, there is no HMO. In the appendix, a graph is given that shows migration of employees from one healthcare plan to another. The trend is for employees with the consumer-driven healthcare plan to the low-deductible PPO. The enrollment of those in the HMO is steady. Has anyone reached out to those employees to find out why they stay in the HMO? Based on my communication with UNLV employees, my perspective as Faculty Senate Chair is that the HMO EPO should continue to be an option. The low deductible PPO should either be converted to PPO Option 1 or left as is. Under no circumstances should PPO Option 2 be approved. You have received dozens of written statements and public comments. Our employees are terrified about the repercussions of losing their current healthcare plans. Do the right thing, keep the HMO, EPO, and do not convert the low deductible PPO to Option 2. In the words of a UNLV employee who has contacted me, we are all more than just dollars saved. Thank you.
Thank you. Kelly, you have permission to speak. Please slowly spell or state and spell your name for the record if you wish to make public comment.
Hi, my name is Kelly Sherrado, Kellyscherado. I am the interim Chief Human Resources Officer for the Nevada System for Higher Education, and I'm speaking on behalf of Chancellor Patty Charlton for the Nevada System for Higher Education, as well as the Chair and Vice Chair of the Nevada System of Higher Education Board of Regents. The Nevada System of Higher Education stands in support of our employees who have expressed significant concerns about the proposed changes to the PPO, HMO, and EPO plans PEB announced in late 2024. As one of Nevada's largest employers, we believe it's our duty to advocate for the well-being of our employees and their families. The changes under consideration will directly affect over 6,000 NSHE employees and by extension, thousands of their family members. As of December 2024, NSHE has over 600 employees enrolled in the EPO plan, approximately 4,200 employees enrolled in the low deductible PPO plan, and around 1,000 employees in the HMO plan. The proposed changes will disrupt coverage for these individuals, leaving many with uncertainty about the cost and accessibility of their medical care. While we understand that PEB's goal is to reduce costs in administering these programs, the lack of clarity and preparation for these changes has raised significant concerns among our employees. At the PEB board meeting on November 21st, 2024, 20 INSHE employees called in and another 50 submitted written comments in opposition to the recommended changes. During this time and since then, INSHE's received communications from countless employees voicing their distress if these recommendations were approved. The concerns INSHE has heard from employees across our 8 institutions can be summarized in 3 key themes: continuity of care, financial impact, and overall plan clarity. Under continuity of care, INSHE employees share their concern about the disruption to the ongoing medical care, including having to change providers, resulting in delays in treatment or the need to reestablish relationships with new providers, scheduling delays due to waiting for new insurance cards or adjustments to coverage, and disruptions to ongoing treatment for serious medical issues, causing potential setbacks to health outcomes. Under financial impact, employees currently enrolled in the HMO plan rely on its predictability. They know how much they will pay for their doctor visits and treatment, allowing them to budget accordingly. The proposed elimination of the HMO plan raises the following concerns: increased out-of-pocket costs for employees, potentially leading to delayed or avoided care due to financial uncertainty, and a loss of the copay structure, which many employees prefer over plans requiring deductibles that can result in unexpected medical expenses. Under overall plan clarity, in addition to employee concerns surrounding the elimination of healthcare plans, we've also received recurring feedback surrounding what many say is a lack of detailed information regarding the proposed changes. Specifically, employees express frustration with the lack of comparisons between existing plans and proposed alternatives, and a desire for clear explanations of how coverage, cost, and provider networks could change. There is insufficient information about the projected cost of retaining current plans versus transitioning to new plans, and employees are requesting additional education and training sessions from PEB to help them navigate changes and making informed decisions. In conclusion, INSHE opposes the proposed changes to the PPO, HMO, and EPO plans because of the significant concerns raised by our employees. These changes, as outlined, would cause disruptions to healthcare access, create financial uncertainty, and potentially erode the trust employees place in their benefits. We urge PEB to reconsider these changes and prioritize the needs of employees and their families by maintaining the current plans. However, if PEB determines that some changes must proceed, we encourage a thoughtful approach to minimize disruption. This could include providing detailed comparisons of the current and proposed change, offering comprehensive education and outreach to help employees understand their options, and adopting a phased implementation timeline to allow employees adequate time to prepare for and adjust to the changes. INSHE remains committed to advocating for the health and well-being of our employees and their families. We appreciate PEB's efforts to balance program costs with quality benefits, but don't feel the proposed changes are the right course of action at this time. Thank you.
Thank you. Kent Irvin, please slowly state and spell your name for the record if you wish to make public comment.
Good morning, Chair Grimmer, Executive Officer Glover, and members. Kent Irvin, E-R-V-I-N, for the Nevada Faculty Alliance, the independent association of professional employees at Nevada's public colleges and universities. We work to empower our members to be fully engaged in our mission to help students succeed. I have submitted detailed written comments on behalf of the Nevada Faculty Alliance, so I will be brief here. We oppose the elimination of the HMO EPO option, and the proposed modifications to the low deductible plan do not fulfill the same purpose. We ask the board to keep the plan design as it is with 3 options, at least for plan year 2026. Making a major change during a legislative session and when there are many unanswered questions and much opposition from members would be a mistake. It might well backfire at the legislature. So, Please retain the HMO EPO option and postpone changes to the low deductible plan until plan year 2027 and after better engagement with and education of our members. Thank you for your consideration.
Thank you, Mr. Irvin. Jennifer Carr, please slowly state and spell your name for the record if you wish to make public comment.
Good morning, this is Jennifer Carr, Jennifer-Carr. I am an employee of the state of Nevada. I have been for 28 and a half years. I am the insured for our family, and we're on the low deductible PPO, which I have been appreciating for the last couple of years that it's been available. I have permission from my daughter Lindsay Carr to speak on our UMR ordeal. She's also on the line today and may provide additional perspective. But I wanted to make sure that we provided the perspective that you might not be getting by simply reading reports from your vendors. Our particular case and many of the things that I struggle with UMR don't ever get to an appeal stage, so you may not receive information on them. For Lindsay, in 2023, or 2024, excuse me, she is 23. She's in grad school at UNR. And during 2024, she's been battling cancer. She's had 2 surgeries and 2 cancer treatment procedures, one to plan her treatment in July and one to execute that treatment in September. For the surgeries, I've had to spend time addressing surprise billing issues, which have been worth hundreds of dollars. And the last one that I'm still working on has been a struggle for over 6 months from her last surgery back in June. But very much worse, however, is our denials and struggles with the 2 cancer procedures, leaving us with a denial total of over $52,000. The most egregious part is that UMR is playing games. The procedures were coded into the system by Carson Tahoe Hospital's pre-authorization department and rejected out with documentation that no pre-authorization was required. Then, when UMR processes the billings, they're denied for no pre-authorization received. Each time I have spent hours, many hours on the phone with Carson Tahoe Hospital's pre-auth department, who has been fabulous, in UMR, and with the most recent round of my struggles with Sierra Healthcare Options, the pre-authorization entity. We've done retroactive pre-authorization, which was also kicked back initially to Carson Tahoe Hospital as no pre-authorization required again, but somehow it did eventually get to Sierra Healthcare Options, and we're working through the September billing at this point in time. I even have letters from Sierra Healthcare Options granting retroactive pre-authorization, and they are still being denied by UNR's claims department. In early October, when the first billing was denied for no pre-authorization, Carson Tahoe Hospital's reaction was, this is really a poster child for the struggle that Carson Tahoe Hospital has been having with UMR. And it was immediately elevated to additional levels of supervision and management at Carson Tahoe to advocate and assist on our issue, and to continue to try to work between Carson Tahoe and UMR to address these issues and not, end up in the position that we're in with Carson Tahoe right now in Northern Nevada. Most recently, in my discussion with the Carson Tahoe Hospital pre-auth rep, she shared with me that she has had 11 of these major issues just in the last 2 weeks, and I spoke with her last Monday. And there are 26 people on her team that are having similar cases. She further shared that Prominence Health Plan and Aetna both do better, and UMR is just clearly, engaging in these shenanigans that are completely unacceptable. As administrator for the Division of Environmental Protection, I also want to advocate for all of my employees. I have 280 of them. And the mental health toll on patients is also unacceptable. Lindsay has had me to take these reins while she has dealt with her health issues and go to grad school at the same time. But not everyone has such an advocate to fight for their issues while they themselves are going through major or even just routine health issues. I want to stick up for them now as much as anything. the loss of Carson Tahoe Hospital as a result of UMR's shenanigans is, again, unacceptable. Carson Tahoe Hospital providers have literally saved my daughter's life. The type of cancer she had could metastasize to lung cancer, and the physicians and surgeons and endocrinologists and everyone she's been working with have gone just to great lengths to treat her well and treat her condition well. And we need to make sure that Carson Tahoe remains a provider for Northern Nevada, and we need a better third-party administrator that is not UMR. Thank you.
Thank you. Just a reminder, those who have made their public comment already, I'm kind of asking because we have over 63 attendees in our lobby currently. If you've already made your public comments, I'm please asking to watch the YouTube link live stream instead of being in the lobby, so I don't accidentally call upon you. Caller with the last 4 digits 0891. Please slowly state and spell your name for the record if you wish to make a public comment.
Yes, thank you. Good morning. My name is Terry Laird, TerriLaird. Good morning, Executive Officer Glover, Board Chair Grimmer, and fellow board members and staff. I'm the Executive Director for RPEN, the Retired Public Employees of Nevada. We're a nonprofit, nonpartisan organization with chapters throughout the state, and we were created in 1976, nearly 50 years ago, to protect the pensions and benefits earned by all public employees. In the first couple of years in our new year, we've received several phone calls from members who've had a lot of struggles with the Medicare exchange, as well as the Carson Tahoe Hospital effect that you just heard about, and others who made the mistake of leaving the Medicare exchange for something less expensive during open enrollment, and only after they switched realized that the mistake, how much it cost them. One of the benefits of membership in RPEN is our good working relationship with PEB and also with PERS, and our ability to reach out to Ms. Glover and know she will do her best to help our members. The same holds true with Chris Garcia at Via Benefits. I know Ms. Glover has been too busy to write our Health Matters column in our member newsletter that we mail to nearly 7,000 RPEN members statewide, many who are in PEB. However, I asked Mr. Garcia if he would be willing to step up and provide the column for us, and he happily agreed. So we're very happy that the experts will be speaking to all our members about what happens when you look for something outside of the Medicare exchange, since PEB only now puts information online only. Speaking of Via Benefits, we are happy to see that PEB has an item before you today to consider renewing the Via Benefits contract. The original Extend Health, when it started, had some issues, but we believe now that many are accustomed to it, and we were hesitant to see a new vendor come in. So we hope that will be approved today. Because there's another legislative session around the corner, and RPEN and our Public Employee Coalition will be lobbying for an increase in the health reimbursement arrangement, HRA, currently $13 per month for years of service. We asked for a $2 increase at the last session, and we will be back to get that hopefully this session, since it wasn't approved the last time. Also, I would like to go on the record in support of the issues that folks are having with the HMO. It sounds dire, and we're hoping that you can answer their concerns today. We thank the PEB staff and the board for the hard work you do for your participants, many of whom are also members of RPEN. Thank you.
Thank you. Lindsay Carr, you have permission to speak. Please slowly state and spell your name for the record if we should make public comment.
Yes, Lindsay Carr, LINDSAYCARR. Thank you to the board for giving us the opportunity for public comment today. As my mom, Jennifer Carr, who was just previously mentioned, I'm a 23-year-old graduate student that's halfway through the Counseling Master's program at UNR. I am also a young adult cancer survivor, recently told that I was in remission. She was also here for public comment today, and you heard from her the story of my cancer treatment nearly being denied coverage. My plea for this board is to consider looking into other options than UMR for our state insurance plan, if that is a possibility. As a young adult cancer survivor, I can tell you firsthand that working with UMR has been a nightmare in the most difficult period of my life. I walked through hell going through this cancer treatment, and UMR did not make it any easier. I was diagnosed with stage 1 of an aggressive type of thyroid cancer in April 2024, meaning that my doctors wanted to treat it as aggressively as possible to give me the best prognosis. And my treatment was a whirlwind of multiple surgeries, some fun stuff called radioactive iodine that makes you very sick and have to isolate from people for days at a time, in addition to other things. On top of this, UMR tried to deny coverage for my radioactive iodine treatments, in addition to Carson Tahoe denying me simple procedures at the hospital like getting the required blood work for my treatments, since UMR evidently had not paid them for months and they started refusing to work with UMR and thus me moving forward. In the future, if we continue to have UMR as our insurance plan, I will lose access to my cancer care doctor. If you have anyone in your life that has had cancer and has gone into remission, you know that cancer care continues years into remission. I will hopefully be able to go back to my endocrinologist, who is also my cancer care doctor, and retain access to my ear, nose, and throat surgeon, who would do any further surgeries if I were to have a recurrence. But if we were to continue with UMR, since Carson Tahoe Health is having so many issues with UMR as an insurance company, I would lose access to all of those doctors in my care network. I urge you to try to find another option than UMR for our insurance plan. Nevadans like me, an employee of UNR and a future therapist that will work providing low-cost therapy to your colleagues, like my mother, an employee of NDEP, like all of us who work for our home state, we deserve better than this. Thank you.
Thank you. Caller with the last 4 digits, 2157. Please press *6 to unmute, and please slowly state and spell your name for the record. Let's go to someone else. Caller with the last 4 digits, 8853. Please press *6 to unmute, and please slowly state and spell your name for the record.
Doug Unger, D-O-U-G-U-N-G-E-R, Acting President, UNLV Chapter, Nevada Faculty Alliance, and Chair of the Government Affairs Committee, also a member of the UNLV Employee Benefits Advisory Committee. Thank you, Chair Grimmer and the PEB Board for your service and consideration. Faculty and staff at UNLV strongly oppose the elimination of the HMO plan in the South, still under consideration. Furthermore, we find the Siegel document, HMO EPO viability, to be flawed in its representations when it obviously blends both HMO and EPO costs versus benefits into a case for elimination when the actual costs of the plans are so different. Dare we state this feels wrong to do, perhaps even unethical to do, when so much is at stake for the future of a third choice for state employee health care. The EPO in the North has a troubled cost versus benefit history. Indeed, it has always functioned as a plan closer in spirit to a PPO than a true HMO. This is not the case with the HMO in the South, demonstrated by its stable enrollment numbers compared to the Northern Nevada EPO, which indicates some degree of member satisfaction. This brings up an oft-debated question. Why must PEB offer similar health plan choices in the North and the South when the costs and provider networks are so different? Other states separate out employee healthcare plans geographically. Look at Oregon as a comparable example. Oregon offers differing menus of healthcare plans regionally, reflecting its service area and provider network differences. Why can't Nevada do the same? Furthermore, not enough feedback has been gathered by PEB fully to comprehend real-life patient impacts of eliminating the HMO and EPO. We recommend PEB keep both the HMO and EPO plans at least through the next enrollment year, while actively soliciting employee feedback by detailed surveys and hosting town halls. At least PEB members would be more prepared and might better understand such a drastic change in health plan choices. In conclusion, based on the Siegel document, it appears that PEB is considering changes to the LDPPO by either a PPO1 option or a PPO2 option. We judge the PPO1 option provides improved benefits versus costs than the PPO2 option, and it does not levy burdensome deductibles. If changes in the PPO plan must be made for next year's enrollment, we strongly request that the PPO 1 plan to be offered as an optimal choice to show that Nevada cares for and values its employees. Thank you.
Thank you. Sorry if I butchered this. Agrella 2, please slowly state and spell your name for the record if you wish to make public comment. Angela, please slowly state and spell your name for the record if you wish to make public comment. Okay. Angela P, please slowly state and spell your name for the record if you wish to make public comment. Oh, let's see. Austin Connell, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Bridget P, please slowly state and spell your name for the record if you wish to make public comment. Claudia, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Claudia, I see that you're unmuted. Can you hear me? Okay. I might try to come back to you. Thank you. One moment. Dan, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. David Cooper, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment.
Good morning. My name is David Cooper, DAVID COOPER, and I'm here today as the chair of the Nevada State University Faculty Senate to speak on Agenda Item 7 with regards to the proposed elimination of the HMO EPO options for healthcare coverage. Like many of my colleagues, I'm here to ask the board to vote against this elimination. These plans offer a valuable choice in how to receive healthcare in Nevada. Many of the people on these options rely on the predictability of pricing and the comfort of knowledge that no single health crisis will financially ruin them. Even if the annual cost of other programs are lower than that of the HMO EPO plans, that does not mitigate the spacing out of those costs, as it does not help if all of those costs are consolidated to a single large payment. My fellow faculty who are on the HMO currently have also talked to me about the worry that they are being forced to switch health plans. They have told me how they are concerned that they will need to find new providers and rebuild relationship with doctors that have been years in the making. They have stated that they are aware of the differences between the standard PPO and HMO plans and have chosen the HMO plan because that offers them the best path for their healthcare needs. Please do not eliminate this option for them. Thank you for your time.
Thank you. Brian Cordova, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment.
Just listening.
Just listening. Okay, thank you. Delana T, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment.
Hi, my name is Delana Tonigan, DELAYNA TONOGAN, and I'm a faculty member with UNLV. I would just like to ask to not have the HMO be eliminated from our plan. Like many of the other colleagues that have spoken before me, many of us are experiencing a lot of healthcare needs that are on a consistent basis because we have chronic needs. And to have the HMO plan is comforting, knowing that we are able to have our predictable copays. We know when we are going to be able to see our providers. We have an established sense of relationship with them. And that really leads to our overall care. Not only are we talking about our physical health, but in conjunction with that, having that rapport with your providers also leads to a good mental health. And those are very important to work together when we are trying to heal ourselves. For my situation, I have a husband who is on the hopes of getting listed for a liver transplant. So we've been working for that process since July. So it's very disheartening to hear that this might not be an option for us that is reasonable as far as the coverage of our financial situation if the HMO plan is eliminated. So I know I'm one of many people who are on here today speaking to you all, but I really hope you do take that into consideration as far as our future and just really look out for the employees that you have. Thank you.
Thank you. Claudia, you have permission to speak. Please slowly state and spell your name for the record to give public comment. Claudia, I see your hand is up, but I cannot, we cannot hear you. Sorry, Claudia, we'll come back to you. Diana, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Gabe Rodriguez, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Hey Sam Selim, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Hey, as a reminder, if you do not wish to make public comment, please leave the Zoom attendee lobby and watch the YouTube live stream on the link is located on the agenda for this meeting. Hugh Wang, please slowly, if you have permission to speak, please slowly state and spell your name for the record if you wish to make public comment. Mark V, please slowly state and spell your name for the record if you wish to make public comment. Mark, are you there? I heard something.
Do you hear me now?
Yes, I do.
Okay, perfect. It's Mark Valentine, MarkValentin, and I was speaking on keeping the HMO. I am on the PPO myself, but I was on the HMO, and I do have a lot of coworkers, very close coworkers that are on the HMO plan that do have chronic conditions, and I worry for them if they have to have a disruption of their service. I know how hard it is to go through when you have an insurance change. I've done it a few times, and you have to kind of go back to square one. And I know a lot of people at the university who don't. I'm frankly really concerned if they have to go back to square one and how their health might be affected if they have to change insurance, if they're getting denied on things they were previously approved for. And so one of the great things about working at UNLV was having a consistent health insurance in the HMO plan and not having to worry about out-of-pocket costs. And it's disheartening to hear that they are trying to get rid of one of the few plans we have. So I really would implore that that we keep the HMO, that we have so many workers here that it is crucial for their mental and physical health well-being that they have that plan. So let's hope we keep that.
Awesome. Thank you, Mark. Caller with the last four digits, 2157. You have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Dropped off. Kimberly Dawes, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment.
My apologies, I'm in there incorrectly. Please remove me. I'm sorry.
No problem. Thank you. Marcy, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. McNulty 6, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Michael A, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Caller with the last four digits, 7132. Please press *6 to unmute, and please slowly state and spell your name for the record if you wish to make public comment.
Hello, can you hear me?
Yes, we can.
Hello, my name is Josnelly Lopez Bravo. I am an admin assistant 2 with the state of Nevada, and I wanted to have a public comment that I did submit to the board, but I did also want to let it be heard. So, dear board members, I hope this year is going well for you. First and foremost, I wanted to comment regarding the Obesity Care Management Program. On May 23rd, 2024, board member Michelle Kelly stated, participants really want access to these medications, referring to the weight loss medications. And obviously, I would hope they make people healthier. But you know, PEBP, certainly as it's currently funded, we just couldn't afford to cover these. And then just also a comment more for public that they're also the line of diabetes drugs. And we do cover those for people who have type 2 diabetes. Those necessary medications are actually covered, end quote. I'm writing this to express my concern regarding the current limitations of the Obesity Care Management Program. While I appreciate the program's intention to promote healthier lifestyles, I believe it falls short in several key areas. Firstly, the program appears to have limited medication coverage currently restricted to phentermine-type medications. This information was not readily accessible to members requiring direct inquiry with PEBP support. I did try to call UMR as well as Express Scripts. Secondly, the current program structure seems to prioritize addressing health issues after they arise, exampling the type 2 diabetes that she quoted. Rather than proactively preventing them, this approach appears to prioritize cost containment over member well-being, as members are burdened with copays and deductibles for conditions that could have potentially been mitigated through more comprehensive preventative care. Thirdly, while PEBP offers resources like Hinge Health app, as well as Real Appeal, in the Obesity Care Management Program lacks the necessary tools for members to fully optimize its use. This includes limited medication options, hindering the ability for many members to achieve their health goals. I propose that the Obesity Care Management Program be expanded to include a wider range of medications such as the GLP-1s for those who require them to address potential cost concerns, and optimal premium could be introduced for those expanded coverage similar to the opt-in programs like life insurance or vision. This would allow members to choose a level of coverage that best suits their individual needs and budgets. I believe that a revised approach would better serve the needs of our members and providing them with tools and resources necessary to achieve and maintain optimal health. Thank you for your time.
Thank you. Scott, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Shauna Rivers, please slowly state and spell your name for the record if you wish to make public comment. Susan, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Tony Terrell, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Claudia, let's try you again. Please slowly state and spell your name for the record.
Hello, can you hear me?
Yes, we can. Thank you.
Thank you. Claudia Cedillo, Claudia Cedillo. I'm an administrative assistant at UNLV, and my comments, thank you so much for taking them, are on two things. One is I know someone very close to me here that is on the HMO and highly depends on their treatment. They've had cancer more than once. It's been a devastating ride. And they've had to struggle and fight to get coverage, to get appropriate health care. And it's somebody that's a colleague that I care about very much. Now, regarding my personal experience with UMR, when I first started here a few years ago, the PPO, I had the regular PPO and I had excellent doctors. I really started to get healthier with some conditions that I have. And then slowly I started seeing the providers leave to where I would go and I would search for providers that had good ratings. All of the ratings were low. It's like I'm searching for the bottom of the barrel to see who's on top of that. I just feel like the quality and the care that I've gotten, which I'm now on the low deductible PPO, has gone down as well. My latest provider that I just found about a year ago, I finally found someone that had good ratings and seemed to care about my health. She's no longer contracted as well. It seems like UMR is just somehow weeding out the good people that treat us and they're leaving for some reason. At the same time, I have to continuously talk to the doctor's office and to anywhere I might have testing. I have to have regular testing. And if the coding is incorrect or the wording is incorrect, I'll get hit with a $500 deductible, which should be covered. If I didn't learn about this, if I didn't call constantly and try to figure things out on my own, I would be left paying $500 every time I go to the doctors for certain testing that I need done. I come from a different state where an HMO is $30 a month. A PPO is about maybe 150, but the care that I've gotten is completely different. We have places like Kaiser where you go in with an HMO, you know what you're paying when you go to see a doctor. Your healthcare is easy, it's covered, but just basic things with women's healthcare are easy to navigate, whereas UMR has made it extremely difficult. And like I said, for some reason, all of the providers that have been good and that I've dealt with that I felt comfortable with, they're not contracted anymore. So now I'm left again having to start over and look for a new provider and try to get my healthcare established and go through the routine of, are you sending my lab work requests correctly? And I've had to call the place where I'm going to 4 or 5 times until they finally have the order correct. And I'll delay in my own healthcare and in my own testing because I know if I go and I don't have that code correct, I have to pay $500. And it's just happened several times. And it doesn't matter what doctor, it's just a constant fight to try to get appropriate health care and covered the way it should be. I just wanted to let you know that it's been difficult with the system that's there now, but taking away something like the HMO for those who use it and really depend on it is really devastating. So, as the other young lady, I forgot her name, that was going through the cancer treatment, as she said, maybe consider something aside from UMR. I don't know if we can get other kind of healthcare up here, but it would really help retain employees and it would help take care of the people who work for the government. Thank you so much for your time.
Thank you. Tiffany or Tiffany Howard, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. John M., you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Andrew P., you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. John Jacobs, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. John, I see that you're unmuted.
Oh, sorry. My name is John Jacobs, John, last name Jacobs. I've worked at UNLV for 27 years now. And when I started out with the HMO plan. I am a diabetic. As a diabetic, type 1, I didn't choose to be a diabetic. So coming into the university, I was somewhat limited to what options I had that would allow me to receive care with the pre-existing condition. HMO has been a blessing for me for the past 27 years. My wife is under the HMO plan as well too, through my employment, and this benefits our family tremendously. I just can't imagine living without having the HMO. Or a health insurance that doesn't provide as much quality care that I currently get through the HMO. I spent half my life with the university. I will end up retiring here. And I just hope that, the value that I put into the university, into our community, into our state is appreciated. And I hope that you reconsider, getting rid of the HMO policy. Thank you.
Thank you. Will the caller with the last four digits 2560, please press *6 to unmute. You have permission to speak. Please slowly state and spell your name for the record.
Hi, my name is Michael Wager. MICHAELWAGNER. I would just like to make a comment on Carson Tahoe Health and on the Aetna Medical Advantage Plan and Humana's Medical Advantage Plan. Carson Tahoe just sent a letter out that they are going to get rid of coverage by Aetna and Humana, and they are pushing us to go to coverage by either the local HMOs, or I should say local Medicare Advantage plans, which are not covered by PEB or by via benefits. And I would like to have that rectified. Thanks. Bye.
Thank you. Carolyn Arita, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Okay. We still have about 19 people in our attendee lobby. Those who want to make public comments, please raise your hand on the Zoom app and I will call upon you. If not, I may ask for you to hang out in the lobby and then I will call back on you during the second public comment agenda item towards the end of the meeting. Michael A., you have permission to speak. Please slowly state and spell your name for the record.
Michael Amesquita, Michael Amesquita. I did public comment last time. In between now and then, I now have to have shoulder surgery, which I would not be able to afford, period, if you took away the HMO. I think something else that has been brought up a lot this time around is the ungodful level of low healthcare in Nevada, in Southern Nevada. I have had Kaiser in California. I have had University of Utah healthcare system, and I've had George Washington Medical Faculty Associate. And here in Nevada, it is so hard to find good healthcare that is not a redone, remade business office into a medical office, and it's scattered and it's horrible. I've never seen anything like it, and I'm 50 and I've worked at 3 or 4 universities. If you all remove the HMO, it'll disproportionately affect people of marginalized backgrounds and color. I don't know if you figured that out yet. And so please don't do this now, because we now have a president who may lift tariffs, and that's going to make everything more expensive. Please do not make healthcare more expensive for us. Thank you.
Thank you. Since I've called upon the majority of the people that are still in the lobby, I'll give you all one more opportunity to raise your hand if you wish to make public comments in case you are still just listening in. Okay, so what I'm going to do, Madam Chair, we do have one other public comment with a member. I'm going to change my configuration out slightly, so just one moment, okay?
Thank you.
Thank you. Okay. Sorry, one moment. And may I ask that everyone besides David Kelsey and
interpreter.
everyone besides David Kelsey and Michelle, please turn off your video camera at this time. David Kelsey, you're good to go, or Michelle, can you let him know to start whenever he's ready?
Okay, thank
Thank
you.
you. Sorry about that.
Good morning. I very much appreciate you listening to my comments. My name is David Kelsey, David. My last name is Kelsey. And I have concerns regarding the elimination of the HMO because my husband and I, specifically my husband, we utilize it. Now understand, my husband has type 2 diabetes. And so this affects him having various chronic conditions relating to it. With the elimination of the HMO, that would increase our coverage, our costs that we would have to pay out. And so thank you so much. I appreciate your time for hearing my concerns.
Thank you. And can you tell David thank you as well?
Thank you.
Perfect. Okay, Madam Chair, that concludes public comment for this agenda item. And as a reminder for those who were not able to give public comment due to a technical issue, or they weren't available when I called upon you due to the volume of public comment, you will be able to present your public comment again towards the end of the meeting.
Okay, thank you very much. We will now close agenda item number 2 and go on to agenda item number 3. PEB board disclosures for applicable board meeting agenda items. Deputy Attorney General Radhika Kanal.
Thank you, Chair Grimmer. Good morning, everyone. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for Public Employee Benefits Program PEB benefits. Pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEB benefits or whose families are eligible for PEB benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEB benefits. At this time, I invite any member of the board who has any additional disclosure to make it now. Thank you.
Oh, and Madam Chair, Jessica Crane has something to say real quick. We're trying to get Stacy Weeks in the lobby, but I'll have her take over.
Hi, this is Jess Crane. I just wanted to put on record that Stacy is in attendance. She is not absent for today's meeting.
Yeah, she's in the attendee lobby. We're trying to move her over as a panelist right now, so she has to accept it. There she is. Or go ahead, Madam Chair.
Okay, thank you. Okay, seeing no additional disclosures being brought forward, I'll close agenda item number 3 and move on to agenda item number 4. Consent agenda. Consent agenda, all items for possible action. Consent items will be considered together and acted on in one motion unless an item is removed to be considered separately by the board. Are there any items the board wishes to pull? Yes, Jessica?
Sorry, I didn't realize my hand was still up. I'll take that down.
Is there any discussion by the board? Okay, seeing none, I will, do I have a motion to approve this item?
Michelle Kelly, for the record, I'll make a motion to accept the consent agenda as presented in the meeting packet.
Thank you. Do we have a second?
Betsy Strasberg, second.
Perfect. We have a motion and a second. Is there any further discussion? Okay, seeing none, I'll call for the vote. All those in favor signify by saying aye.
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 All those opposed? Okay, motion passes. We'll close agenda item number 4 and move on to agenda item number 5. Discussion and possible action regarding enhancements to current supplemental health voluntary benefit offerings. Nick Proper and Neil Haggerty. And this is for possible action. Please go ahead.
Thank you, Chair Grimmer. Nick Proper for the record. I'm providing a report on supplemental health voluntary benefits. With CoreStream, we offer 6 supplemental health benefits, and these are accident, critical illness, hospital indemnity, additional life insurance, short-term disability, and long-term disability plans, and they're all bundled with the standard. Well, CoreStream released an RFP for these same supplemental health products, and based on the results, we recommend moving the bundled offerings to MetLife, beginning plan year 26, including this upcoming open enrollment. And with that recommendation, if approved, we'll create a communication plan. And since MetLife is currently integrated with CoreStream, there's actually there's no action required of members, as all the policies will be transferred over. So it'll be seamless. Members can continue the same policy, or they could, port it to an individual policy with a standard. But our recommendation is to move these bundled offerings to MetLife. With that, we can pause for questions or move to Neil with CoreStream to provide, a brief overview and answer additional questions if needed.
Okay, thank you for that. Are there any questions or discussion?
Michelle Kelly for the record. I have a question or two. I think they're easy ones. Thank you for the agenda item. And Michelle Kelly for the record, MICHAGLLEKELLEY. I just have a couple of questions. Firstly, I noticed that the life insurance that MetLife has agreed to do a guaranteed issue for the next open enrollment for all employees. And I'm just wondering, it doesn't say how much. So what would be the limit on the guaranteed issue that MetLife are offering?
Nick Proper for the record. Neil, can you answer that?
Yeah, Neil Hegarty for the record, NEALEHEGARTY. I can go ahead and look that up right now. Nick will take me about 1 minute, but I can answer that question shortly.
I just have a second, I think, question as well on that line. So for the rest of those products, so the accident and critical care hospital indemnity, do they have waiting periods when people sign up, or are they automatically guaranteed issue whether you're new hire or sign up during open enrollment?
This is Neil Hegarty, though. There is no waiting period, and they are a guarantee issue if you sign up during open enrollment.
Thank you.
Hey, any other questions? Okay, seeing none, do I have a motion on this item?
And Neil Hegarty, just to answer your question, the guarantee issue level for employee is $100,000 and for spouse is $25,000.
Thank you. With that, I'll make a motion to accept the agenda item as presented and to switch our voluntary product offerings as listed to MetLife from the standard.
Okay, thank you. Do we have a second?
Jennifer McClendon, I'll second it.
Thank you. Is there any further discussion? Okay, seeing none, all those in favor signify by saying aye. Aye.
Aye.
Aye.
All those opposed? Okay, motion passes. We will close agenda item number 5 and move on to agenda item number 6. Executive Officer Report, Celestina Glover, information and discussion. Please go ahead.
Thank you. Good morning. This is Celestina Glover, Celestina, last name Glover, GLO, as in Victor, ER. Before you is the Executive Officer Report, which gives the board and members of the public updates on agency operations. The first thing in the report is recently we had a presentation before the Interim Retirement and Benefits Committee per NRS 287.0425. PEB is required to present certain reports whenever this committee meets. They met on December 17th, and we did come with our presentation as required. The primary questions that came out of that meeting were related to the percentage increase when comparing the HMO to the self-funded plans. The percent was lower with the HMO, but the dollar amount that the HMO started at was a higher amount. So when comparing the self-funded plans to the HMO, in 2024, the PMPM per member per month cost was $186 versus the self-funded plans where the PMPM was approximately $150. So although we saw a greater percent increase, the per member cost is still lower than the HMO for 2024. In addition, the committee observed cancer treatment being a top diagnosis for PEB members, and they were questioning whether or not care was being received outside of the state. And in many cases, that is the situation. They wanted to know what percent of individuals went out of state and primarily the reason why. We did present a report to them which showed that 10.6% of members in 2024 did seek care outside of Nevada. Some of the reasons for that was provider referrals, member preference, and we also use a lot of centers of excellence outside of Nevada that may provide some specialty care that's not available in the state. So this report was provided to the committee as requested. The next item on the report is the governor's recommended budget. I know many people watch the state of the state and may have some questions. We submitted our budget per our request back in August, as it was due on August 30th by close of business that day. Everything that PEB requested was included in the budget. We essentially kept our budget the same as we have. We made adjustments to account for the shortage in our reserve categories. We also asked to increase the subsidy for the Part B premium that members are required to purchase if they are Medicare age and are retired. And the only thing that was done a little bit differently from what we typically do, PEB will put in the experience and trend for our plans based on an analysis that Siegel provides and our observation in our utilization reports. Typically what happens is we may put in that we believe the increase is 6%. The governor's finance office generally will reduce that to match what Medicaid and corrections utilizes. That doesn't always work for PEB. So this year, what they've done is they've reduced what we put in the budget, but what they did do is give us an enhancement unit to make up the difference. So assuming that the legislature agrees with our increase that we believe is going to happen, because that's what's been going on for the last 3 years, rather than being cut to 3%, we should see the increases toward our subsidies and our overall budget costs so that we can continue to fund our plans. And then finally, the Carson Tahoe issue. At the last board meeting, the PEB board directed staff to release an RFP to get a secondary network that would include the Carson Tahoe Hospital and providers under their umbrella. That RFP is being worked on. We're hoping to release it in the early part of February of 2025. During that time, I've also had contact with Carson Tahoe. Specifically, Melissa Williams has called me or has emailed me, and they have agreed to extend their existing contract to the end of the calendar year, so December 31st, 2025, to allow us sufficient time to get the RFP released and then to complete their implementation process once a new vendor is selected. So there will be some outreach probably from Michelle Whalen, our CFO, to request members to sit on the evaluation committee. And then finally, for the moment, the board meetings will be held virtually until the end of the session. Right now, session, of course, ends in the beginning of June. We may have the May 2025 meeting in person if we are close to being done with PEB business, but we will let the board and the public know if there's any changes there. But currently, we are looking at March and May also being virtual. And with that, I'll take any questions.
Okay, is there any discussion? Okay, seeing none, I'll close agenda item number 6 and move on to agenda item number 7. Discussion and possible action regarding continuing to offer HMO and EPO option. Celestina Glover for possible action.
Thank you. This is Celestina Glover. Before you is the summary of the EPO and HMO plan sunset. We presented this originally in September. The board asked that we come back with additional information, which Siegel has put together a presentation to provide that additional information. That report was sent to the board members in December so that they would have time to actually review it before this meeting. There's a lot of discussion about whether or not this should happen or shouldn't happen. I understand that there's concerns, but if you will look at the report that Siegel put together, it does show that the majority of those providers are in our network anyway. In addition to that, with the RFP for Carson Tahoe, we don't know if we'll pick up additional providers through that process. So we are looking at trying to make the transition, should the board approve it, as smooth as possible. And we are taking into consideration the concerns that our members have. We have released an RFP for the HMO because the one that we currently have is expiring at the end of this plan year, which is June 30th, 2025. We have results of that RFP. They will be discussed in a closed session if the board has questions. None of that can be discussed in this open meeting at this point. So if there are questions, we will need to close the meeting to the public and only have the board and the appropriate vendors in that meeting. And that will be Siegel as they do our analysis of the results. So and with that, I can turn it over to Siegel to talk about their presentation.
Thank you.
Officer Glover. Good morning. This is Richard Ward. Sound check. Am I coming through okay?
Yes, you are, Richard.
Okay. Should I share the slide deck or does everybody have their own copy? What would be preferable in this setting?
Actually, I think it would be better if you shared it so then I could pin the ASL interpreter on the top corner of it.
Bear with me 1 second here.
No problem. Thank you, Richard.
Okay. Get this full screen. All right, what's that showing for everybody? Okay.
Looks good on our end, Richard. Thank you.
All right, thank you. Good morning to board members and staff and anybody in the public that is in the meeting. I'm going to start off here with a review of some of the materials that we've discussed in prior meetings. The first slide here is a review of the current plan designs for the 4 plan options, with the understanding that the EPO and the HMO are offered or priced on a blended basis when members are making plan elections. The EPO and the PPO, I want to point out, are primarily copay driven. There are some elements that have coinsurance, in particular inpatient hospitalization, and then when there's lab screenings or other diagnostic services that are tied to a surgery or an office visit, those are subject to the deductible if there is one, and coinsurance. Whereas in the HMO, almost everything is copay driven. The actuarial value in the first line shows that the low deductible PPO and the EPO have very similar overall plan values. And just as a reminder, the actuarial value is a measure of the portion of total cost that's paid by the plan. So just as an example here, the low deductible PPO has about an 85% actuarial value. And what that means is that for every $1,000 of total costs, the plan pays $852, and the member pays the remaining $148 in, well, there's not a deductible, but in copays, coinsurance, and that's on average across the whole plan. Of course, out-of-pocket amounts and levels will vary based off of utilization and circumstances. And then at the bottom, we show the employee only premium, with the CDHP plan having the lowest premium at about $55, the PPO at $85, and then the EPO and HMO blended to be about $100 higher at about $181. The recap of a summary. This is also material that we've reviewed in prior meetings. The EPO and the HMO is the highest cost option. I don't think that's news to anybody. This is primarily driven by the EPO currently. The costs in the EPO are higher than in the HMO. The HMO premiums have been contractually suppressed. The claims costs that we see that are reported by Health Plan of Nevada are higher than the premiums, and we expect that over time that's not sustainable, that the premiums will catch up, that no insurance company is going to subsidize any group's costs over a prolonged period of time. And reviewing the premiums, we just reviewed that. The EPO and HMO premiums are roughly 2 times the premiums in the PPO and about 3 times the premiums in the CDHP, and those are the employee premiums. And we do have ongoing migration over the last couple of years from both the EPO and the HMO to the low deductible health plan. There has been more migration from the EPO, but the HMO enrollment is also declining year over year. And as we reviewed, the low deductible PPO is the most efficient plan. So just as a reminder, that's when we consider costs, plan design, value, and then the health risk in the group in each of the plans. And the low deductible PPO shows to be in aggregate the plan that provides care in the most efficient manner. And the EPO is the least efficient plan of the 3 self-insured plans. This is a review of costs over the last several years for the EPO at the top on a PMPM basis. For the self-insured plans, we have netted out pharmacy rebates. So these are net claims costs. For the HMO, we are using the premium because that's the cost to PEB is the premium. The top line, the light green, is the EPO. The darker blue navy line just below that is blended between the HMO and the EPO. And then the bottom three lines are grouped together. That's the CDHP, the low deductible health plan, and the HMO. Over the next several years, we expect the low deductible health plan and the CDHP to trend forward at market trends and have a flatter trend line than the EPO and the HMO if those continue to be blended. And this is because we expect the suppressed premiums of the HMO to increase at a higher rate than the other plans to catch up to the cost of the HMO. And then after a few years, we expect the EPO and the HMO to be comparable in cost. And so that's the gray line there in the middle is the HMO increasing at a more rapid rate than the other plans. And the dark blue or the navy line there in the middle between the green and the gray line, that's the blended rate. So that's also going to increase at a higher trend than the other two plans. At the September board meeting, there was discussion and questions from the board about provider access and disruption. And so we worked with UMR and with Health Plan of Nevada to review HMO experience, and if the HMO or the EPO are sunsetted, what would be the disruption, and then what would be the access for the members that were in those plans. So the first comment is that the CDHP, the low deductible PPO, and the EPO all use the same network. So there's no disruption for if the EPO is sunsetted. Have access to the same providers that people in the EPO have today, with the addition of access to non-network providers that the EPO doesn't currently cover. For the HMO, we reviewed current members, current utilization, and the providers that were utilized by people in the HMO, and those were compared against the providers in the UHC network, and we see that there is significant overlap. That's a table in the middle. So we see that the vast majority, well, all hospitals are in both networks, almost all PCPs, and then almost all specialists. And there are actually a few providers that aren't in the HMO network that are in the UHC network. So there'd be a net enhancement of access, just looking at the raw numbers here. We would lose 3 PCPs from the HMO network, but gain an additional 15 PCPs. And then looking at the bottom here, just a measure of access, which is we may use the term geo access. This is looking at where each member lives, and then do they have access? Does that particular member have access to a hospital within 15 miles of where they live? Do they have access to 2 primary care physicians within 10 miles of where they live, and then 2 specialty physicians within 15 miles of where they live? And between the HMO network and the UHC network, the access is virtually the same. And in all cases is over 99%, which is a very good result when looking at this sort of access measurement. So next we looked at the particular patients that are using that would be disrupted, or that are using HMO network providers that would no longer be in network. And we see that there are 10 patients that utilize the PCPs that would not be in network in the UHC network, but only 5 of those patients are still enrolled in the HMO. So we have five individuals that are utilizing or have utilized providers that we expect would become out of network in the UH if the HMO is sunsetted. And so we can see the number of claims associated with that. And this is measured as of November 1st. So a few months have passed since then. But we see that there would be five members that would be potentially affected by this change. And in situations like this, I don't want to speak for Health Plan of Nevada or UMR or UHC, but oftentimes when there's a transition like this, there'll be an outreach to the providers that are currently not participating in the UHC network to see if they would contract with UHC. And then we can see below, the table below is for specialty providers, especially physicians, and there's most of the claim, 30% of the claims, not most, but a good number of the claims are for sleep studies. And you can see the other specialists that are utilized that are not in the UHC network. And this represents the number of patients is there are, I believe, so there's 49 patients and 94 claims associated with this utilization. So again, I would expect, not to speak on their behalf, but I would expect that UHC may reach out to these specialists to attempt to get them to contract with the UHC network if the HMO is sunsetted. At the September board meeting, there was also a question about what do the out-of-pocket costs look like, or what would they be between the different plans. So we developed a couple of straw person scenarios here of particular instances. We looked at claims data in the detailed claims data that we have, and we used some specific real-life examples here to review what the members' out-of-pocket would be for a given year, accounting for both the premium and the member cost share associated with coverage, which would be deductibles, copays, co-insurance. And we developed 4 distinct scenarios and then looked at them for employee and family coverage at different levels of cost. And we did not include the HMO here for a couple of reasons. One, we don't have the detailed claims data for the HMO that we have for the other plans, so we wouldn't be able to, in the same way, extract an actual case study or an actual example that occurred. And we also, in our opinion, the benefit levels are comparable, and with both between the EPO and the HMO, and with both plans being very copay driven, the results we think would be very comparable, and actually the HMO would have slightly lower out of pocket than the EPO. So the first one that we have here is someone who only has routine care. So they have routine preventive care. They have an annual physical, the recommended preventive screenings, and so they really have no out of pocket because those sort of services are covered at 100%. So they only have the annual premium. And so this first example here for employee only coverage is really just a comparison of the monthly premiums annualized. For family, same thing. Annual physical, 2 annual physicals. We assumed a family of 2 parents and multiple children. So 2 annual physicals, 2 well child visits, and then the relevant preventive screenings for their age and overall and health risk and demographic. So again, no member cost share, no out of pocket associated with those services. Next, we reviewed examples of what we would consider to be low to moderate care. So the next step up where there is some member cost share. And so for the employee, not only did the employee have an annual physical and the applicable preventive screenings, but they're also on 2 maintenance medications, 1 brand, 1 generic, and they had 1 emergency room visit. And so we ran that through the cost share, reviewed the out of pocket in the claims data, and due to the deductible and co-insurance nature of the CDHP, they would hit the maximum out of pocket for the year, and then add that to the premium. And at this level with this example, the CDHP would have the highest out of pocket once you combine the premium and the out of pocket associated with care, and then much lower out of pockets for the low deductible PPO and the EPO. And once combined with the premium, the low deductible PPO has the lowest total spend for the year. And then for family coverage, we're layering on from the prior example some additional care and service needs. So the annual physicals, annual well child visits, preventive screenings, a couple of ER visits, an urgent care visit, 1 outpatient surgery, and then multiple medications for this family. And again, the CDHP has the highest at total spend. The low deductible PPO has the lowest, and the EPO is right in the middle, with the EPO having the lowest member cost share, not considering premium. So the lowest cost of care in deductibles, copays, and so on. Okay, so now moving up maybe one more layer where there's an inpatient stay for that's added to the care needs for single employee. And again, the CDHP is the highest total spend, has the highest total spend. The low deductible PPO has the lowest, and the EPO, consistent with the other examples, has the lowest member cost share, but the highest overall total spend. And at this level of care and costs, the total cost for the 3 plans, there's less separation between from low to high. And then for family coverage, they're added a normal maternity and newborn delivery to the care needs. And in this instance, the family hits the out of pocket for the CDHP, and the out of pocket is not met for the low deductible PPO or the EPO. And similar results where the low deductible PPO has the lowest total costs once you consider the premium. The CDHP has the highest total costs, and the EPO has the lowest costs associated with care, the out of pocket associated with care needs, with deductibles, copays, and other cost sharing mechanisms. And then we looked at high utilization, where the care needs in all plans result in the member out of pocket being reached. And so when the member out of pocket is maxed out in all plans, the CDHP is actually the lowest cost plan because the maximum out of pockets for the 3 plans are very comparable, and the CDHP has the lowest premium. So members that expect to reach their max out of pocket in a given year would be better off overall by choosing the CDHP plan. I do want to mention, we have it in a footnote here, but this doesn't consider that some of the member cost share in the CDHP plan would be offset by an HSA balance if the member has one. So this is just strictly their exposure. So in the single coverage, if they got a $600 HSA allocation for the year, that $4,000 would actually be $3,400. At the September board meeting, there were questions about the number of members that reach the out-of-pocket. And so we coordinated with UMR for the 3 self-insured plans. And we see that in the CDHP, largely because of the co-insurance, we have, and the higher cost share, about 36% reach the out-of-pocket. The blue here, the 15% is single coverage, and 21% is from the other 3 tiers for employees that cover family members, whether it's family or plus one or plus spouse, plus child or plus spouse. And the low deductible health plan and the EPO, the portion that is hitting the max out of pocket is lower, and that's largely due to that coverage being more copay driven. So members, just for the same level of care, have less out of pocket for the same services, and so their out of pocket costs will accrue at a slower rate towards a max out of pocket, and so a lower portion of the people in those plans hit their max out of pocket. If the EPO and the HMO are sunsetted, we've had some discussions about revising the low deductible PPO as the other plan along with the CDHP. And so for some perspective, we reviewed plan designs and premiums for PPOs and high deductible health plans for other comparable states in the West. And the reason that these states were selected is that in the West, they are the most similar to Nevada. And by that, I mean California, Oregon, Washington, and Hawaii have Kaiser, and Kaiser because of Kaiser, the healthcare markets in those states are very different. And there's a lot of insured plans. For example, in California, you have very large entities that are 100% insured. The city of Los Angeles is 100% insured for Kaiser and for the other carriers that they have. So it's a different healthcare market than in Nevada. And also, the state health plans in California, Oregon, and Washington, and Hawaii are significantly larger than in Nevada. PEB is comparable in size to the other state health plans in Alaska, Arizona, Colorado, Idaho, Montana, New Mexico, Utah, and Wyoming. And those states are largely also self-insured. So you have comparable size. You don't have the same HMO, in particular Kaiser, influence in the markets. So in comparing the plan designs and the employee premiums with Nevada and with PEB, we think is a good same fruit sort of comparison. And since we're using this as perspective to consider what a reimagined or redesigned PPO would look like, we didn't include HMOs in this benchmarking review. I also want to mention that when reviewing market data or benchmark data, that it's done as a snapshot in time. And so here we're having a discussion about what the board and what PEB might do for plan year 26. And you're thinking about what those benefit design features can look like and what the premiums can look like next year. What we're looking at here are the benefits and the costs that were in place in calendar year 24. So those other states are also thinking about what they're going to do in 2026 And so it's a bit of a moving target. So I think that's helpful. That's helpful context here when reviewing how PEB compares with your other peers, your other peer states. Okay, so we looked at, there's some highlights, some monthly premiums. The premiums for employee coverage for PEB are, let me just provide some grounding here on what this graph and the table shows. So we're showing the minimum, the maximum, and the average for all 4 tiers. And single coverage for the low deductible PPO is a little bit below the average. The average is in the far right column, so $85 versus $94. And so it sits in the middle between the minimum and the maximum near the average. And then for the other tiers, the employee plus spouse is higher than the average, and employee plus children is about on average, and employee plus family is higher than on average. We just have these showing these as actual dollar amounts and then a graphical representation. We also looked at deductibles, and there's only one state that has a separate pharmacy deductible. And so we looked at overall deductibles on a combined basis, and on a combined basis, the deductible on average is $550. It's going down about 2/3 of the way in that table on the far right. And the low deductible health plan has a $0 deductible, so it's lower than even the minimum for the states that we reviewed. For the maximum out of pocket, there are some states that have a separate maximum out of pocket, but we reviewed on a combined basis so that we're looking at the total annual exposure that a member might have. And going down to the bottom there, we have individual and family out of pocket max comparisons. And for the low deductible PPO, it's at $4,000. That's a little bit below than the average, which is about $4,500. And you can see the range there is $2,750 to $7,350. And then for family at $8,000 for PEB, that's a little bit lower than the average, which is about $9,800. You can see the range is $5,500 to $14,700. We also looked at office visit. We looked at copays for office visits, urgent care, and emergency care. And overall, for physicians, the copays are in line with the average for the market. So the table on the left, $30 for PCPs compared to a $26 average, specialists $50 versus an average of $44, and then urgent care and ER visits are quite a bit higher than what we see in the market. In the peer group, and urgent care is actually higher than the maximum for the peer states. Next, we looked at pharmacy, and generally, other states also utilize copays. So all of the PEB plans, or all the PPO plans, the non-CDH plans, use a primarily copay-based design for cost share for outpatient pharmacy. And so for generic medications, you see right in line, $10 currently compared to an average of 11. And there's not much variation in the market, 10 versus 50, a minimum of 10 to a maximum of 15, and with the average being 11. Most of these states are at the $10 level. We start to see some more variation for brand medications. So PEB is at $40 for formulary for preferred brand, compared to an average of $34, and then $75 for non-preferred or non-formulary, compared to about $60 in the market. And then in specialty, PEB is a little more favorable than the average. Next slide just holds all of that together into a line-by-line comparison. and then adds including the premium at the bottom. So just to review, the deductible for the low deductible PPO compares favorably since there isn't one. The out-of-pocket maximum, and it's in general, and it slots in near the midpoint, near the averages compared to those other states. The office visit copays for PCP and specialists are also fairly in line with the averages. Urgent care and ER visits are higher. Prescription drug copays compare pretty well with what we see on average from the other states. And then for the premium, just showing the single premium here, that's pretty comparable to the average. And there's quite a bit of variation in the market among those plans, from $30 to about $150 for their highest value PPO. We also looked at CDHP plans and the deductible. We just have this one slide here to show the line items. The annual deductible at $1,600 currently for PEB is just below the average of about $1,800 for the peer group. And not all states, all of the other states have high deductible health plans. I'll comment there. The HSA, the account balance, the account allocation for the year at $600 for PEB is right in line with the average for the other states. Coinsurance compares favorably well. The out-of-pocket maximum is a little bit below the average. The office visit is coinsurance driven, like most of the others are, and that's right in line with the average. Same with urgent care and emergency room visits. Interestingly, though, PEB is a bit of an outlier, with drug coverage in the CDHP plan being coinsurance driven. So PEB, the plan design in PEB is coinsurance up and down the line, which is very straightforward and consistent with a lot of other CDHP plans in the market in general. But the states in the West that have high deductible health plans utilize a copay driven benefit. So but that's after meeting the deductible. So they just have copays after meeting the deductible instead of coinsurance. And then the premiums range from $0 to $80 with an average of $30 for single coverage, and PEB's premium is $55 currently. This next slide. So with that context of how does the current PPO and the CDHP compare with other states, we reviewed the current plan designs for the PPO and considered how those could be updated to consider a number of factors. So one factor is that if the EPO and the HMO are sunsetted, then those plans being largely copay driven, the board has expressed concern about having plans that are not having a plan option, not having a plan option that is copay driven or heavily copay driven or almost exclusively copay driven. So the PPO plan designs, one of them, the PPO option 1, has a larger is more copay driven. So in particular, for primary care and specialist office visits, about halfway down, the $30 and $60 copays that are in this proposed or plan design would also cover any associated testing, lab scans, etc. So you go in for an office visit and the physician orders a diagnostic test to further investigate what conditions or symptoms you might be presenting to try to determine what the course of treatment would be. In PPO option 1, those would not incur additional costs. So there wouldn't be a co-insurance component associated with those additional tests and screenings with this benefit design. Also compared to the current low deductible health plan, inpatient hospital would be, rather than 20% co-insurance, would be a $750 copay. So this mirrors the HMO design and the EPO design that for inpatient has a fixed dollar benefit. In outpatient surgery, currently the PPO has a $500 copay, and this the PPO option 1 and PPO option 2 also have a copay, but there's a difference in the benefit between the HMO and the EPO. The HMO incentivizes utilization at ambulatory facilities, so non-hospital surgical centers, which are considered to be more efficient sites of care. So there's a copay difference that mirrors the differential in the current HMO that does not exist in the EPO currently. So if you're having a joint replacement, as an example, and you can do so on an outpatient basis, then you can do so not in a hospital setting, then the copay will be lower if you choose to go to a surgical center. Now and then also I'll highlight at the top here, the deductible. PPO option 1 maintains a $0 deductible that the current low deductible health PPO plan has. PPO option 2 introduces a $500 deductible, and that's offered for consideration for a few reasons. One, we see in the peer group data that the other PPOs have a deductible, so wanted to develop an option here that introduces a deductible. Also, differential here is the out-of-pocket maximum for these plans. Currently, the EPO and the HMO have a $5,000 maximum out-of-pocket, so we're maintaining that. So that would be an increase compared to the low deductible PPO. In PPO option 2, the $30 and $60 copays does not cover any additional associated testing, lab scans, etc. That would be covered by the deductible and the co-insurance. So there is that is I think a material difference here that has been a topic of discussion over the last several board meetings. And then the rest of the coverage items are identical between the plans. Now, the difference in the deductible, there being a deductible, and then how additional testing, lab scans, etc., how that's covered between the two plans, one being covered by deductible and co-insurance, or subject to deductible and co-insurance, and the other being covered by the copay. Those differentials are, there's a cost associated with that. And that difference, going to the top line there, that difference is about 4 percentage points. So 87.1 compared to 82.8 actuarial value or plan value. So the plan would pick up about 4% more in total costs between these two PPO options. And PPO option 1 is a richer plan design than the current low deductible health plan, and PPO option 2 is a leaner plan design. I skipped over the CDHP to focus on the PPO, but there should be some changes to the CDHP in the deductible and in the deductible to align with IRS requirements for the plan to continue to be HS qualified for health savings accounts to be an HSA qualified plan. That's an annual exercise here for PEB, as the required deductibles by the feds are indexed and may change from year to year. PEB's deductibles mirror those changes. So that's just a regulatory driven change from one year to the next. So we also looked at the multi-year projection for introducing or transitioning, sunsetting the EPO and the HMO, and then replacing the low deductible PPO with either one of these two options. Looking at PPO option 1, or what would happen with PPO option 1, there's a small amount of savings year over year. So for plan year 26, there would be about $500,000 in savings, and that would grow to about $2 million compared to a baseline projection. So that's largely due to the enhanced benefit design in the PPO option 1 compared to the current low deductible PPO. Now, there would be some savings, largely from sunsetting the HMO. The premiums include a fair amount of retention, higher admin levels, so there's margin for profit and for risk. That's common. I mean, that is always the case with insured premiums. PEB would also get access to pharmacy rebates or enhanced pharmacy rebates, and so there's some savings that come with sunsetting the HMO, and then there'd also be reduced trend for the HMO, because remember, we expect that to catch up over time. And then for PPO option 2, we would see more savings, largely due to, so there's still the same savings for the sunsetting the HMO, and then the PPO option 1 has a leaner plan design. And so there's savings associated with that plan design differential. We also expect there to be savings as people migrate to the PPO, which has shown to be the more efficient plan of the 3 self-insured plan options. So with PPO option 1, we would see about $15 million in expected savings in plan year 26, and then that growing to about $22 million over the 5-year period here through plan year 30, excuse me. This assumes that employee premiums would be set in a manner comparable to historic practices. So the prior slides, these figures are net PEB costs, which are net of the employee premiums, and the employee premiums are driven by plan design as well as funding from the state. So the AGIS and REGI, which are the funding mechanisms for retirees and active employees, are being considered right now for the next biennium and have not been finalized yet. So that is a key driver of what the employee premiums will be, and then also the plan design that's decided by the board of PEB. But we expect that if the EPO and the HMO are eliminated, the CDHP premiums will be comparable to what they are now and what they would be without sunsetting the EPO and the HMO, which would still be within the range of the peer group. And then for the low deductible health plan, we do think the premiums would increase because there's higher cost members in the EPO and the HMO would largely migrate to the low deductible health plan, which would increase the cost for that plan. But we think that may be a moderate increase and would still compare well against the peer group. I know I'm mentioning often how PEB compares with the peer group. I want I want to acknowledge and comment that really PEB situation is PEB situation. We're just providing, shouldn't necessarily make decisions based off of what your peers are doing, but we do think it's helpful context to see what's going on and what other states are doing, how they price their plans, and how they design their plans. So now back to out-of-pocket considerations here. We have PPO option 1 and PPO option 2 compared to the CDHP, the low deductible PPO, and the EPO. And for single and family, we just looked at case 3 here, the high moderate utilization, which is the next to highest, not the highest one, but the one just below that. And for PPO option 1, the member cost share is lower than for the low deductible PPO, but it is a little bit higher than the EPO. And then since PPO option 2 has a leaner plan design, the out-of-pocket is higher than PPO option 1. And but both of them have a lower total spend based off of these estimated premiums. We don't really know yet what the premiums are going to be until we know what the funding is from the state. And then, but based off of our current estimates, either of those two plans would have the lowest total out of pocket. And then for family coverage, we see much the same. PPO option 1 is lower. Actually, both PPOs are lower than the current low deductible PPO, but higher than the EPO from a member cost share perspective, and then from a total spend perspective, both of them would be lower than any of the current 3 plans once you consider premiums and member out of pocket. And that concludes the prepared materials. I'll pause for questions and discussion. And let me know if I should take down the slides.
Board members, are there any questions?
Richard, you could bring down the slide too if you like.
Yes, Michelle. You're on mute, Michelle.
Sorry, thank you. I'm sorry, I do have a lot of, I would like to see the results of the RFP before I have a lot of questions, but I think many of them are predicated on understanding what the RFP looks like. But I'm also conscious that Executive Officer Glover had her hand up before me, and I wonder if she had something to add to the conversation before that. So.
Go ahead.
Thank you. This is Celestina Glover. So I just wanted to include additional comments to the presentation that Mr. Ward gave. What we are proposing, depending on obviously what the board decides, if we sunset the EPO and the HMO, our recommendation is to consider option 1. So there is no deductible in the new low deductible PPO plan. Low deductible is a misnomer because there is no deductible in that plan. So we're proposing we just refer to it as the PPO. In addition, if the board opts not to sunset either plan, outside of the required change to the deductible in the CDHP, which the board did approve in September, in order to maintain the HSA qualification, that we make no changes to plan design for the low deductible, the EPO, or the HMO outside of benefit changes that might have to happen should the funding not come through from the state, because we don't receive the funding necessary to support the plans. Obviously, premium will go up. So we just have to make sure that we keep that in mind. Also, decisions cannot be deferred because we need to start the rate setting process. So regardless of the decision, whether it's sunsetting the plans or not, we need to make that decision today so we can get the rates set, because we need to bring those back to the March meeting. So those are just some considerations to get the questions answered on the results of the RFP for the HMO. That will need to be done in the closed session. And at the same time, we'll review the Medicare exchange RFP results as well. And that's agenda item 8. We'll do that all in one closed session so we don't have to close, open, and close. So with that, I will get off of here.
Okay, so for agenda item number 7, do we have a motion to approve? Yes. Board Member Kelly.
Thank you, Michelle Kelly, for the record. So firstly, I have a comment. I do want it on record. I want to thank Executive Officer Glover, the PEB staff, and CEGA for bringing forward this item. We have to, as a board, I think we have to explore all options to keep the PEB program healthy and viable for our participants. But I also want to thank all of the participants for the last 3 months, including Christmas Day. I have received public comment directly from participants, explaining, just their concern about the potential loss of the HMO. I am the NSHE South representative, and that's where most of my, the participants who've outreached me have come from. And it's really, honestly, it's been quite overwhelming, the number of public comments I've received. And I want to thank our participants for that, because I do think it's important that they are engaged in these decisions, because everything we do impacts them. So I do appreciate everyone taking their time and sharing their stories. And obviously I've spent a lot of time, because every time I've had these public comments, I've re-engaged the issue and, understanding both staff's point of view and our participants' needs. But I do think this is a major shift in direction for PEB. And so I have a lot of concerns. I have questions about the presentation, but I do think my concerns are really not in the detail of the presentation. But one of the big gaps for me in the presentation is that we actually compete for employees, both the state of Nevada and NSHE, with city and local county governments. And so I don't really know what they offer their participants, but certainly in the last few years, I think that's where many of our skilled, highly trained employees have gone to, not just because of health insurance, but for many reasons, but health insurance is one of their considerations. So I would say that, for a number of reasons, I think I've got 7 reasons after listening to the presentation and public comment, I am not in favor of sunsetting the EPO HMO this year. I think, employee morale and employee needs this year are really important. And I think we're probably going to have a retirement contribution increase this year. We've heard from employees about the continuity of care, just the way they like to pay for their health insurance. They like to front load through their premium so that they don't have to deal with billing or anything like that when they seek services. So I think that, I think employee morale and just the cost of living stuff at the moment is very loud for everybody. And so for that reason, I think it's a bad time to sunset the HMO and EPO. The other thing that came to light, I think that really clarified for me during public comment today is that, you know, we continue to have issues with UMR and their billing practices and the network access. And, you know, I saw the, obviously we saw the disruption report, but you know, it seems like UMR is not coping with the volume of business we have right now. So what will adding, you know, 4,000 or 5,000 participants and all of their dependents do to that? You know, we also don't know. So there's also some unknowns now. So we don't know what the RFP for the second network might show. And that might actually enhance this conversation and make it a lot easier. You know, let's see. The legislative session, in the last 2 sessions, the legislators have actually overwritten some of the decisions the board made due to public outrage or participant outrage. I don't know what the right word is, but certainly the activism has undercut some of the decisions we made. And I think just from the volume of public comment around this issue, I think that the legislators could override us anyway. And so I think we should let them know what we're planning for 2027 and see what they have to say. The next unknown is just something brand new, and that is, I see Stacey on the in the meeting, but what is the Nevada Health Authority? You know, how's that going to change the dynamics here? You know, I have no idea. I don't know if even Stacey knows that right now, but certainly, you know, it's another aspect of unknown. And then just my last, this is very argumentative, so I apologize, and then I'm going to be quiet and let someone else have some air. It is the EPO that's pushing this conversation. It's the EPO that is, you know, a very expensive plan that works like a PPO. And so honestly, if we actually have to take this step, then I think we need to separate. The HMO in the South is viable. Well, I haven't seen the RFP results, but assuming we got a bid and it's, you know, it's acceptable, the HMO is viable and we could separate that out. Yes, you know, I'm sorry for Northern participants that there's not potentially a viable HMO there, but I don't really see why a large geographic center in Nevada has to be punished because there's not a viable option in the North. Thank you very much for your time.
Thank you. Are there any other comments from the board members?
I have my hand up, Joy. Stacey Weeks for the record.
Go ahead.
I agree with Michelle Kelly. I think we need to wait. I think there's enough going on during session. I think something does need to change in how we purchase healthcare with large carriers across all of our markets. I think the opportunities are different now, and they can be in the next year for state employees. And so I would support what Michelle said and wait. And I also really appreciated the feedback from the recipients. I think going forward, we really do need to think about the needs of our state employees. And I know we all care about them at this table or we wouldn't be here, and our retirees, but you know, we have very little to offer in Nevada, sometimes in salary. And the one thing that we should be offering is really good benefits. And so I think it behooves us to wait, get through session, see what happens with this new authority and purchasing strategy that we can achieve maybe a better deal. And I think the board deserves a chance to look at those opportunities. So I'm going to stop there, Joy, but that's where I'm at right now. Thank you.
Okay, thank you. Any further comments?
Yes, this is Jim Barnes. I'm in agreement with Stacey and Michelle. I think we should wait.
Okay, thank you for the comment. Betsy?
Hi, this is Betsy Strasburg. I mean, this is probably the first time I'm going through the presentation, and I think it's important to let the participants also be informed in the same way as we are if there needs to make a change. And I don't think that we have given them the opportunity to understand the ramifications of their healthcare by any potential change. So I do not support making changes at this time. I think that, as the other speaker said, we should wait until the session is over, find out what we are allowed to do, and also give them a heads up of what might be happening when PEB goes to present their budget to the legislature. Thank you.
Thank you. Okay, so this item is for possible action. Council, do I need to take a vote on tabling the item?
Can I make a comment?
Yes, go ahead, Executive Director.
So this is Celestina Glover. We would need to actually vote to not sunset the plans versus tabling it, because tabling it makes it sound like we're going to bring it back before the next plan year even starts, which we can't do. There's no time for that. I also, depending on whether or not we close the session to talk about the RFP results, one of the things that I will need to move forward is that the board would need to approve moving forward with the award of a contract, which would be done in the open meeting, and also allow me as the executive officer to finalize any negotiations and to sign the contract so we can get it to BOE by the next deadline. So there's a couple of things that need to happen in there. It's similar to what is needed in agenda item 8. So whatever the motion is needs to include those things. Thank you.
Thank you. Do I have a motion?
It's Michelle Kelly here. I will make an attempt to start a motion, and if anyone wants to make a friendly amendment, please feel free to do so that I capture everything that Executive Officer Glover requested. Okay, so I make a motion that we continue to offer the HMO EPO plan through plan year 2026, right? 2026, on the condition that we have that we can enter into a viable contract with the selected bidder for the RFP for the HMO product in the South. And as part of that the Executive Officer Glover have the authority to negotiate with the HMO provider to enter into a satisfactory contract.
Thank you.
And to sign the contract. Sorry.
I accept that friendly amendment, and to sign a contract with the HMO provider.
Okay, thank you. Do I have a second?
This is Jim Barnes. I'll second that motion.
Okay. Any further discussion?
This is Betsy Strasberg. So my question is maybe I didn't catch it, is the proposal to separate the EPO and the HMO when Director Glover goes to negotiate and sign the contract?
No, my motion was that we continue to offer the HMO EPO product. The EPO, though, is self-funded, so there's no contract with that, whereas our contract with the HMO expires on June 30th. So we need a new contract.
Okay.
Okay, any further discussion? Okay, seeing none, all those in favor signify by saying aye.
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 All opposed? Okay, motion passes. We will move on to agenda item 7.1. Discussion of possible action regarding a potential contract with Health Plan of Nevada, Inc. to provide a fully insured regional health maintenance organization, HMO, medical and pharmacy group plan for PEBS active employees and non-Medicaid eligible retiree populations. A portion of this item may be conducted in closed session to allow a review of the results of the evaluation of proposals for the contract in accordance with NRS 287.04345, Section 4. Any action on the contract, including potentially awarding the contract pursuant to NRS 333.335, canceling the request for proposals, or modifying and reissuing the request for proposals will occur in open session in accordance with NRS 287.04345, Section 5. Celestina Glover for possible action.
This is Celestina Glover. So essentially the motion from agenda item 7 covered most of these requirements. So the contract, me signing the contract, finishing negotiations and so forth. What we need to do now is if the board does have specific questions as to the result of the RFP, we do need to close the session to allow those questions to be asked. So that's the first thing. Are there going to be questions on either the RFP HMO or the Medicare Exchange HMO or Medicare Exchange RFP, sorry. And if there are, then we need to go ahead and close the session and only have the board members, staff, and Siegel be a part of that closed meeting.
This is Radhika Kanal for the record. If I may say, jump in here and provide an advice that it should probably go into the closed session pursuant to Chapter 287. I believe we should go into the closed session so executive officer can provide an update on the process and give an opportunity to the board members to discuss and ask any questions you may have.
Okay. With that, do I have a motion to move into closed session?
This is Celestina Glover. I don't think we need a motion to move into the closed session. I think we can just have staff put the slide up for this one, and then I believe the closed session is in Teams.
Yes, Officer Glover. Yeah, I could put up the slide if you'd want for this agenda item. And now are we also going to do it for agenda item 8, not to go a bit too far ahead?
Yes, for the closed session, we'll take both 7.1 and 8 together rather than opening and closing again. And we can discuss both RFPs. We'll take all the actions when we come back to the open meeting, if that makes sense to everybody.
That works. Thank you.
Thank you.
Chair, I'll get the slide going for the I'll let everyone know that the Zoom meeting / the YouTube live stream is still going to be continuing onward. Those who have invites to the closed meeting, please drop from the Zoom meeting, join the separate Teams meeting. And when we have concluded with the Teams meeting, jump back over to Zoom via the email you've received with your panelist invite. Or you could always click on the Zoom link and I'll move you back over. One moment, I'll get the slide up.
Okay, IT, are we back live?
Madam Chair, the notice says the open meeting would resume at 12:15. If you would like to take a short break until we give them an opportunity, or wait till after the 12:15 to begin the meeting, please.
Okay, thank you.
Sorry about that, Madam Chair. I'm getting the slide back up. Couldn't find my mute button. All right, Madam Chair, we are back. It was 12:15.
Okay, good afternoon. Welcome back to the PEB board meeting on January 23rd, 2025. We are coming back from the closed session and we have up for discussion and possible action agenda item number 7.1. Is there any discussion by the board? Okay, do I have a motion on this item?
Michelle Kelly for the record. I make a motion that we accept the RFP committee's recommendation to for Executive Officer Glover to begin negotiations with can I say the companies with the successful bidder to enter into a contract for HMO services in the South and to enter into that contract assuming negotiations are successful.
Okay, thank you. Do I have a second?
This is Jim Barnes. I second the motion.
Okay, thank you. Is there any further discussion? Okay, seeing none, I'll call for the vote. All those in favor signify by saying aye.
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 All those opposed? Okay, motion passes. We will close agenda item 7.1 and move on to agenda item number 8. Are there any questions on agenda item number 8?
So this is Celestina Glover. Just for clarification, as I said, I would repeat the requirement. This agenda item does provide the board the option to take one of 3 actions. They can cancel the request for proposal. They can modify and reissue the request for proposal, or essentially move forward with the award of the contract to the winning vendor. And with this recommendation, I put 2 separate requests, and that is to approve the contract for the Medicare exchange and to allow the executive officer the authority to finalize negotiations and to sign the final contract for submittal to the Board of Examiners. Sorry, my words are getting twisted. Thank you.
Okay, thank you. Do we have a motion on agenda item number 8?
This is Jennifer McClendon. I move to award the contract to the winning vendor. and give Executive Officer Glover the authority to negotiate and sign any contracts related to that action.
Thank you. Do I have a second?
This is Jim Barnes. I second that motion.
Thank you. Okay, having a motion and a second, is there any further discussion? Seeing none, I'll take a vote. All those in favor signify by saying aye.
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 All those opposed? Okay, motion carries. We will close agenda item number 8 and move on to agenda item number 9. Discussion and acceptance of Claim Technologies Incorporated audit findings for State of Nevada Public Employees Benefits Program plans administered by UMR for the period of July 1st, 2024 through September 30th, 2024. Joni Ameo, Claim Technologies Incorporated, for possible action. Please go ahead.
For the record, I'm Joni, Joni, Amato, Amato. The scope of the first quarter audit for 2025 for UMR included claims processed during the period of July 1, 2024 through September 30, 2024, and it included both medical and dental claims. The medical and dental claims paid during the quarter 1 totaled approximately $66 million and included approximately 236,000 claims. The audit included a quarterly performance guarantee validation, 100% electronic screening with 50 targeted samples, a statistically valid stratified random sample audit of 200 claims, and a focused random sample audit of 100 claims from Carson Tahoe Hospital. In our auditor's opinion, UMR's performance and financial accuracy, overall accuracy, claim turnaround time within 14 days all improved this quarter when compared to the prior quarter results. Claim turnaround time within 30 days decreased a bit from the prior quarter. The performance guarantees for overall accuracy, claim turnaround time of 92% processed within 14 days, and 99% processed within 30 days were all met. And although financial accuracy performance did improve in this quarter, it still did not meet the performance guarantee in the contract. And this results in a penalty of 1.5% of the administrative fees for the quarter, or $20,902.26. And in response to a request last year, we've added a new table in the report that you'll find it on page 4 at the end of the executive summary section. And it provides a quick snapshot of UMR's performance for these measures for the most recent 4 quarters. And we'll update this table each quarter with the most recent 4-quarter results. So I hope you all find that helpful. CTI also reviewed the quarterly UMR self-reported performance guarantee results and noted that 26 out of the 27 quarterly results were met. I recommend reviewing the financial accuracy errors identified in the random sample audits to ensure that the root causes have been identified and claim processor training and system corrections have been made where appropriate. And we also recommend reviewing the electronic screening and targeted sample testing results to focus on potential recovery and process improvements in the categories where we did find errors. And finally, as mentioned before, this quarter's audit included an additional focused random sample of 100 claims from Carson Tahoe Hospital for the period, and this included an extra quarter. So this included the April 1, 2024 through September 30th, 2024. The audit identified only one error for an incorrect provider discount applied. CTI did identify 11 claims in that 100 claim sample where Carson Tahoe billed using the incorrect form. And this resulted in the incorrect amount being paid on those 11 claims. These errors were not the result of anything on UMR's part. It was Carson Tahoe identified their error. they rebilled on the correct claim form that they needed to bill on, so the claims could be correctly taken place. So if you have any questions, I'm happy to answer any.
Okay, thank you for that. Board members, are there any questions? Okay, seeing none, do I have a motion to approve this agenda item?
Jennifer McClendon, I move to approve.
Thank you. Do I have a second?
Kelly, I'll second.
Thank you. Any further discussion? Okay, seeing none, I'll call for the vote. All those in favor signify by saying aye.
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 All opposed? Okay, motion carries. We'll close agenda item number 9 and move on to agenda item number 9.1. Response to audit findings overview of performance guarantees for the period of July 1, 2024 through September 30th, 2024. Rhonda Huckabee, UMR, and this is information and for discussion. Please go ahead.
Hi, for the record, this is Rhonda Huckabee with UMR. We would like to thank you for the opportunity to respond to the audit performed by Claims Technologies for Q1, plan year 2025. We are dedicated to improving the overall experience and our commitment to meet all performance guarantees. Per request from the last board meeting, as Joni previously stated, that we are doing a quarter by quarter comparison. So UMR has 39 performance guarantees for claims, network, and UMC administration. In the board packet under agenda item 9.1, page 312, we have included a quarterly breakdown on the self-reported performance guarantees for last plan year and the Q1 2025 audit, which reflects an overall improvement in our remediation progress. We send a monthly performance guarantee report to PEB executive staff, and the goal is to document our efforts and meet the standards established in the remediation plan. We strive to have the highest possible quality and work diligently to address all issues identified in the CTI quarterly audits. We continue to review process improvement opportunities within our organization. We value our partnership with the state of Nevada, and we will continue to work with PEB and their vendor partners to provide high-level service to the participants and the provider community. And we have leadership on the call from operations to address specific questions from PEB board members related to our performance guarantee or the CTI audit results.
Okay, are there any questions, board members? Okay, thank you for your report. Seeing no questions, I will close agenda item number 9.1 and move on to agenda item number 10. Via benefits presentation, Chris Garcia, Willis Towers Watson, for information and discussion. Please go ahead. You're on mute.
Thank you. Sorry about that. Hi, this is Chris Garcia with Willis Towers Watson. Today, I would like to present some information about the services that we provide to PEBs, retirees, and the spouses of those retirees. We're going to go over some general information, but I'm going to share my screen first, so bear with me for one moment. And can you see my screen? Can someone confirm that, please?
Yes, we can.
Thank you. So I have several different items that I'd like to discuss with Nevada PEB today. The first item we'll go over will be just kind of an overall summary of the individual marketplace and what VIA Benefits is, who we are, what kind of services that we can provide to your retiree population, your Medicare eligible retiree population. We'll talk about the retiree experience, how they enroll through us, how they can utilize our services, some of the different communications and different meetings that we have. And then we'll also talk about a big component of what we do, which is the HRA administration and some of the advocacy that we do for your retiree population as well. So first, kind of an overview of who VIA Benefits is. We are the oldest and largest Medicare marketplace in the United States. We have over 18 years of service working with different retiree populations. We have over 2.3 million retirees that we've serviced, over 800 clients right now, and we have processed 5 million applications last year in 2024 across our entire population. And with hundreds of carriers, so over 100 different carriers that are on our platform. We've had 3.2 million retiree conversations in 2024. So that's how many interactions we've had with different inbound calls that we've received across our entire book of business. And then, several different Fortune 500 clients that we work with. And then we do customer satisfaction surveys. We've actually shared some of that information with PEB in our quarterly reporting. And one of our survey questions is if the participant feels like they've enrolled in the best plan that meets their needs, and we typically get responses of around 98% of those retirees are finding that they're enrolling in the best plan that meets their need that's available on our platform. So what is an individual marketplace? So it's an individual marketplace it's a marketplace that individuals can compare and enroll in individual health care plans. And then we offer that personalized help. A marketplace gives expanded choice of plans that fit all needs. We have typically greater affordability with the largest risk pools, right? So there's 4.42 million Medicare eligible participants. We also do we're pre-65 retiree enrollments as well. We don't currently do that for Nevada PEB, but there's a marketplace of over 12 million pre-65 retirees out there. And so we certainly help participants who are interested in utilizing our services and choosing, enrolling in, and using their different plans that we have available to them. And I'll talk about those different plans in just a little bit. And then how the marketplace helps Nevada PEB, we hopefully significantly decrease the administrative burden that would come with managing a retiree population on your own. Typically, we have greater affordability as well as reduced liability. And then we continue to bring value to retired employees and their families. And so how we work. So we've actually been a partner with Nevada PEB since July of 2011. So even longer than I've been with VIA Benefits here, which is great to have you all as a partner since that period of time. We do not charge Nevada PEB for any of the services that VIA Benefits provides to your retirees. So there's no, account costs. We don't charge any HRA administration fees, anything like that. Participants can shop and enroll on different medical plans that meet their needs. We give them education either through printed materials or available on our website. And we also have retiree meetings that we schedule throughout the year. And again, I share a lot of that information in the quarterly board meetings information, the quarterly reporting that we share with the board. We provide lifetime advocacy for enrollees, in which we are the agent of record for their plans that they've enrolled through. And then we also administer the HRA, which is a big component for Nevada PEB based off of the number of people that you have that are eligible for the HRA that submit claims on a regular basis through our services. For the retiree experience, what kind of plans are available on our platform, right? So that's the first thing is the different plans that we have. We have a Medicare Advantage plans, which would be typically have a prescription drug plan included, which would be considered a Part C plan. Medicare supplement plans, which are also referred to as Medigap plans. Prescription drug plans. So if you were to choose, say, a Medicare supplement plan as a retiree to enroll in, that does not typically include a prescription drug plan. You would have to choose a separate prescription drug plan. So we have those available to retirees to enroll in. And then we also offer dental and vision plans as well. Okay. We work with several different carriers. I'm going to flow through this relatively quickly. ARP, Aetna, Anthem, Blue Cross Blue Shield, Nevada, Blue Cross Blue Shield, Cigna, Hometown Health, Humana, United Healthcare, WellCare, WellPoint, as well as numerous other ones, maybe some that are more regional plans. And the good news is that our plans are not just focused in Nevada, right? So you have retirees that live in all 50 states across the country, and we have plans available in every state with different carriers, whether they're a regional carrier or not. These are just some of the top carriers that we have available on our platform. But it gives you a good idea of the types of different insurance carriers that we are working with on a regular basis. How do participants enroll through us, right? So what are the channels that they can contact us to enroll? So we really have two channels in which people can enroll through us. The first being where they can enroll through our website. They can enroll through myviabenefits.com/PEB. And on the website, they can compare different plans by doing a side-to-side comparison. They can select their plan and they can enroll directly on the website. They don't even need to speak to a benefit advisor. If they find a plan that they want and they are happy with that plan, they can go ahead and enroll directly on the website. We do a verification through identity, so it is a secure site. The participants will review their disclaimers and confirm information on the site. So when you're filling out an application for coverage, or a lot of different application disclaimers that have to be processed and read, and the participants take care of all of that right through the website at their own convenience. And then what's good about the website is a lot of older retirees might need assistance, and they can get that assistance through a friend, and that friend can help them review, or even a family member can, of course, help them review that information right on the website. Once they've selected their plan, it takes usually about 15 minutes to complete the process to actually do the enrollment. And that's a lot different than what we'll talk about for the second option, which people can enroll through us, which was enrolling through the phone. So they would call our Via Benefits Service Center phone number that's set up specifically for Nevada PEB. That number is 888-598-7545. It's a toll-free number. And they can call that number and they can set up an appointment to speak with a benefit advisor, or they can call that number without an appointment and speak to a benefit advisor. Typically, the appointments are recommended to ensure that the participant has enough time to do a complete review of the different plans that we have available based off their zip code, and share information in regards to the physicians that they see, the types of prescriptions that they utilize. An enrollment plan typically takes at least 50 minutes. If you're doing it, an enrollment through the phone takes at least 50 minutes, if not longer. So we want to make sure that the person has enough time allowed for that call. So if they call in and they only have 30 minutes, they may not be able to complete the full enrollment call. So an appointment allows them enough time to plan and ensure that they have all the information that they need. But an appointment is not necessary. They can enroll without an appointment. They just want to make sure that they call in with enough time to do so. The benefit advisor will help the participant review the different plans, as I mentioned, and choose a plan. Again, there's a verification that is done of who the participant is over the phone. And then if the participant does want to provide permission over the phone, they can have a family member or friend speak to a benefit advisor to help walk them through any assistance that they might need in regards to reviewing plan information and talking about what plan or plans might best meet the participant's need. Okay. But I think the big thing is both channels are great channels. It really depends on the participant preference. We even have some retirees that will go online, they'll review their plans and shop and compare. And I'll talk about the shop and compare availability in just a moment, but they can shop and compare their plans, and they'll be able to see that they want to call in and then speak to a benefit advisor just to make sure that they made the best decision. And that saves them quite a bit of time over the phone if they shop and compare online first and then call in. So as I mentioned, the shop and compare functionality is available. You can see that it has an estimated annual cost function there. They can shop up to 3 different plans side by side. So you'll see as I move through this slide, it'll highlight different sections of what's available on the website. So they'll see the estimated annual cost there for the plan. You'll see if what drug coverage is available, so formulary covered drugs. If they're in-network doctors, if we have that information from the participant, if they enter in their prescription information, if they enter in the physicians that they see, the tool will utilize all that information and do the shop and compare so they can see what prescriptions are covered and what physicians might be available in that plan or through that network. And then they'll also be able to choose additional plan details, and they can see an expanded list of additional plan information online. So probably very similar to what an active employee would see when shopping and looking at plan information. We carry that type of display and ability to shop and compare plans for the retiree population as well on our site. One important thing to note is that the shop and compare feature on the site can be utilized without an online account. So if somebody is considering retiring and they haven't really officially notified PEB that they're going to be retiring, they can still go out to our website and shop and compare plans and just look and see what's available in their zip code and what those different prices are. Now, of course, premiums increase, typically each year. We'll see some premium increases. So if somebody shops and compares now, but they don't retire until next year, the pricing might be different, but it more gives them an idea of what is available for them to choose from. We have support for your retiree population every step of the way. For their initial enrollment is transitioning, say, from a group plan as an active employee to being a Medicare eligible retiree, and even beyond that, right? So as they age into Medicare and they enroll through us, and what that future support look like. So on a year-round basis, we typically have over 400 licensed agents, as well as 250 plus customer support staff. We bring on seasonal staffing typically during the Medicare open enrollment season. Medicare open enrollment is from October 15th through December 7th. And we typically will bring on staffing starting in the summer to anticipate that additional call volume that we know that we're going to receive during the open enrollment season. So we bring on that additional staff, and then we maintain a lot of that seasonal staff even after the open enrollment season ends, so that we can anticipate additional call volume that we typically see, say, in January and February, just based off of historical call volumes and people calling in, checking on the status of whether it's a claim for the new year or whether it's checking on their plan information for the new year. We want to keep that additional seasonal staffing in place for an extended period of time when applicable. Okay. One thing to note that's about our licensed benefit advisors. I know that this is probably come up in the past from some retirees who've had some concerns. But our licensed benefit advisors, they're not commissioned. They are salaried and they make unbiased decisions. They are looking for the best plan for the participant based off the information that the participant provides to them during the conversation that they have. The licensed benefit advisors, they can make extra additional money, such as a bonus, based off of customer satisfaction scores. It's not based off of enrollment information. So again, it's important to note they are not commissioned. They receive no commissions at all. They are state licensed across the US, and they have to be carrier certified within all regional and national carriers. And so there's a lot of training that they have to go through, a lot of licensing that they have to go through to be able to sell plans in different states throughout the country. So for example, a new benefit advisor who comes on may be only licensed in 4 or 5 different states, but somebody who has a longer tenure with us could be licensed in all 50 states, just depending on their experience and their knowledge and the process that they've gone through to become licensed. The average benefit advisor is 52 years old with over 10 years experience. But of course, we do have some new benefit advisors who are learning the process and getting licensed and getting the different licensures across different states. But they must be licensed, appointed, and certified to speak to retirees and dependents, based off of the different states that they are licensed in. Okay. We do have a workforce management team that manages all of our benefit advisors, our application processors, our regular customer service team members who might, answer a more focused call about the HRA. So the benefit advisors do not answer those HRA calls. We have other representatives that do that, but that workforce management team does all the forecasting and scheduling, and gets everything in place. So we have a great support staff in place to assist retirees and to manage that call volume that we do receive on a regular basis. Okay. Again, benefit advisors, they do provide that concierge service, unbiased. They do senior sensitivity training, which I've had the opportunity to attend in the past, where it's interesting. They'll have the representatives wear specific glasses that are designed to make it be more like somebody who is an older person who might have vision problems. So it gives them a better understanding of what that experience might be for a retiree who receives information in the mail, but it's hard for them to read, and to try to help, just have that sensitivity around some of the challenges that an older retiree might be experiencing, whether it's based off of vision or hearing or something along those lines. They are 100% focused on the retirees. Again, they have to be state licensed and certified. They have to do over 40 plus certification tests. And that's all happens again, typically during the summer when they're gearing up for the Medicare open enrollment season. And then another thing is that all of our licensed benefit advisors are 100% in the United States. So we have different service centers within the United States, as well as some virtual, benefit advisors who service our population. We have 3 different locations. We are in right outside of Salt Lake City, and then right outside of Phoenix, Arizona, and then in Richardson, Texas, which is right outside Dallas. Okay. Once somebody does enroll through us, they're going to get different communications. So they do get a selection confirmation letter. They're going to get that's going to confirm the different plans that they've chosen. They're going to receive information and a packet with their new insurance cards and information about their new plan benefits. That's going to come directly from the insurance carrier. And then via benefits, so our services, we'll send them a welcome letter as well. And then if somebody does qualify for their HRA, I'll talk about it a little bit later on, but they'll get some information from us after they enroll when they qualify for their HRA. One thing to note is we do have educational videos out on our website to help really educate participants on Medicare Part B, the HRA, how to utilize the HRA. I would highly suggest as members of the board, if you get a chance to go out to our website at the my.viabenefits.com/PEB and maybe view those educational materials and those videos. It doesn't take too long, but it kind of gives you an idea of what information we have available to participants when they're looking to get information about the different services that we have available and how to utilize our services, and in particular, how to utilize the HRA. Okay. I mentioned Medicare open enrollment earlier, so this slide really just reiterates the periods of time. This is our busiest time of the year, is October 15th through December 7th, as you can imagine. In particular, that last week of the season, usually the week following Thanksgiving through December 7th is extremely busy. But the key thing that's to note if you're a retiree is that it is a passive enrollment. So if the same plan or plans that you are currently enrolled in are available in the new year, you don't need to take any action if you want to keep those plans. But if you are somebody who is considering changing plans or moving to a different plan, you can certainly contact us, and you can shop and compare on the website and see what new plans might be available that you might want to choose, or you can shop and compare through a benefit advisor through a phone call. I would recommend doing it online first, just because of how busy we are. The phone calls can have longer wait times during the open enrollment season. So shopping and comparing plans online first, and even enrolling in a new plan online would be preferred, but certainly calling us is an option as well. Okay. Moving on to the different communications that we have and the meetings that we do. So we have multifaceted communications. We do print communications, which include educational guides and reminders throughout the course of the year. I've shared some of those communication materials with the board during our quarterly reporting that we provide. We do virtual retiree meetings, in which gives participants an opportunity to ask questions. We do meetings twice a year, once in the spring and then once again in the fall. I've shared information with the board on that when we have those meetings, and that information is in that quarterly reporting as well. We obviously have our website available. It's co-branded with PEB information, and we have the enrollment as well as HRA tools are available. And it is a personal account where that participants will access. They'll set up a user ID and a password to access the account to secure it, as you would typically suspect with like a bank type of situation. And then, of course, we have our phone support with that one-on-one personalized support, whether it's through a regular customer service representative, a benefit advisor. Okay. So I mentioned the virtual retiree meetings. We do those 2 days or 2 meetings per day, and we do a total of 4 virtual meetings right now, 2 in the spring and 2 in the fall. The first meeting is typically going to be focused on people that are aging into Medicare. So new potential retirees who are maybe already retired as pre-65 and now they're aging in and becoming Medicare eligible, or somebody who might be a retiree or an active employee, excuse me, who's over 65, who is considering retiring. And so that meeting is typically focused on Medicare basics. It'll go through Medicare Advantage plans, Medicare supplement plans, prescription drug plan, dental, vision, how they can enroll through us, how they can contact us, how they can set up an appointment. A lot of the information that somebody would need to really get engaged and start considering that transition from either going from a group plan and retiring, or being a pre-65 retiree moving into a Medicare eligible retiree status. Okay. The second meeting that we typically have will be one that's focused on participants that are already enrolled through via benefits. Okay, so that will be focused more on the Medicare open enrollment season when we do the meeting that we do typically in the fall, which is in September, maybe September, October time period, and then it'll also focus more on the HRA and how to utilize the HRA. So that's a meeting that's really designed for people that are already enrolled through us. We don't go too much into the enrollment process, except for maybe if somebody wants to consider making a change, or they have some sort of special enrollment period that they might want to consider making a change to the different plans that they've enrolled through with us. Okay. One of the great thing is that we do record a couple of those different meetings, one of each type, and we put them out on the website. So currently we have the fall version of those meetings available for participants to view. And as the board or anybody can go out onto the website at any time and take a look at those meetings and listen in and kind of see the information that we currently share and make available to participants who would like to view those recordings. I did want to provide some call stats to give you an idea of the volume of calls that we do receive. So this slide shows metrics from 2023 as well as 2024. So you can see the total inbound calls that we have for Nevada PEB. This is specific to PEB. We had over 20,000 calls in 2023 and over 21,000 calls in 2024. The average inbound handle time. So I mentioned like the enrollment calls are typically about an hour, but of course, an HRA type call would typically be less, maybe 10 minutes, 15 minutes or so. So on average, the handle time, so how long we're on the phone with the participant, is usually about 18 minutes and change. So you can see for 2024, it was 18 minutes and 56 seconds. In 2023, it was 18 minutes and 10 seconds. But it kind of gives you an idea of the volume of calls that we're receiving specific to PEB, and then how long those calls on average last. Of course, each experience is a little bit different, depending on why somebody's calling in. So somebody could, certainly call in about an issue that could take longer to review than somebody who is calling in just checking on the status of a payment. But it's, we're here to help them, and our benefit advisors and customer service representatives will engage with the caller as much as they need to and address their situation. They're not pushed to drop the calls or end calls early. They want to help resolve the situation for the participant as much as possible. Some enrollment statistics, just on give you an idea of how many people for Nevada PEB are enrolled through our platform. Again, some of this information is shared in the quarterly presentations that we do provide to the board, but I wanted to summarize, this is the data through the end of 2024 that we have. So for PEB, the total eligible population is around 18,800 people. Of those, we have 13,483 participants that are enrolled through us in a plan as of the end of 2024. So that's 71% of the population has enrolled through us. And then below that, you'll see a chart showing you the different types of plans that participants have enrolled through us, with whether it's a Medicare Advantage plan, a Medicare Supplement plan, a Part D plan, which is prescription drug, dental, or vision. So we have a good breadth of people that are enrolling in those dental and vision plans, as well as the Medicare supplement plans or Medigap plans, as well as Advantage and then the Part D plans. This is pretty consistent with what we've seen historically for Nevada PEB on a regular basis. But it gives you an idea again of the volume of calls that we're getting, as well as the number of participants that we're helping with being their exchange and helping them enroll. Okay. This slide here shows information that is related to people that made plan changes, as well as what we would consider an agent participant. So an agent participant, again, is somebody who is becoming newly eligible through the exchange. And so we receive a data point called a program eligibility start date. And that program eligibility start date would be, if it was in 2024, they're on this report in this bottom section. So for that, I'll focus on that first. We had 668 people that came across with a program eligibility start date in 2024. Of those people, we were able to help convert 621 of them to enroll in some sort of plan through us. Of those, so that's 93% enrollment, which is really high. And that's really great. That means we're reaching a lot of your retirees that are becoming eligible each year and getting enrolled through us. So 93% is a really strong score. Obviously, we would like to help everybody, but some of those people that did not enroll through us, maybe they have a plan available through a spouse, or maybe they decide to retire from PEB or retire as a PEB retiree, and they go to work somewhere else and they have coverage through that new employer. So to say 93% is a really good score. The top chart shows, again, the people that made changes for the new year. And we have some historical data here just to kind of give you an idea of the ebb and flow of what we see from which types of plan changes people are making. Some of it is driven off of industry-wide changes, such as if we're seeing an increase in prescription drug premiums that might draw more people to change prescription drug plans. If we're seeing some changes in Medicare Advantage plan offerings, we might see some more changes there. So for the most recent plan year, so enrolling into 2025, you can see the most changes that we saw were for prescription drug plans. We had over 1,000 people make changes from one prescription drug plan to a new prescription drug plan. For Medicare Advantage plan, we had 474 people change from one Medicare Advantage plan to another Medicare Advantage plan. The other changes are less common. As you can see, historically, that's the case. Typically, you have prescription drug plan to another prescription drug plan being the most common change, or from Medicare Advantage plan to another Medicare Advantage plan. But it gives you, again, idea of the volume that we see during open enrollment and who's making a change for the new year. The next section, we'll talk about HRA administration and advocacy. So one thing about the HRA administration, I'm going to talk a little bit about what it is and how PEB has it set up and how we help administer the services for your retiree population, and then also how participants can submit claims. We have a fully integrated experience. We try to do one call resolution, as well as we have an integrated website. Obviously, not every situation can be resolved in one call. Something might require additional research, or it could be something that is just needed to, have some data updated on an account, and we have to get that data requested and sent over to us. So certainly, as we try to resolve everything in one call, there could be a situation where that doesn't occur. Typically, we'll see for the HRA where the client will be allocating the dollars for each retiree's HRA account. We'll set up that HRA account once the person qualifies for it, and then the retirees are going to be reimbursed through the eligible, for their claims if they're an eligible expense and they're approved. They have different ways, again, that they can reach us. They can do it through the phone. They can do it online, and online is a great tool, and I'll talk about that a little bit more. And then more recently, we have rolled out a mobile app that participants can download to their smart devices. And I'll have a slide later on that talks a bit more about that. But they can actually view balances and they can submit claims right directly on the mobile app. Okay. There is a requirement for the HRA. Participants have, for Nevada PEB, participants must enroll in a Medicare medical plan through via before their enrollment period ends to qualify for the HRA. And then to continue to qualify for the plan, they must remain enrolled in a qualifying plan through via benefits. So they can change plans from one Medicare medical plan to another Medicare medical plan, but if they have a gap and they drop coverage by mistake, then they become disenrolled and disqualified for their HRA. The one exception that PEB has is for people that are on TRICARE. They do receive an exception and they do not need to enroll through via benefits in a Medicare medical plan to qualify for the HRA. They would qualify automatically, but they do need to contact PEB directly to set up that TRICARE exception. Okay. I mentioned earlier when we were talking about communications that there is an additional communication that we do send out after somebody qualifies, and that is the reimbursement guide. So the reimbursement guide will go out to a participant after their account is set up for their HRA, and that reimbursement guide includes information on how they can submit claims, eligible expense list information, how they can set up direct deposit for their account. So a lot of that great information that a participant typically needs to really be successful in utilizing their HRA account. Sorry, let me go back one slide. I moved ahead too quickly. The tax account for the HRA is a tax-free account, right? So it is used to reimburse participants for eligible healthcare expenses. But the key is that the participant will need to pay first, and then they will need to submit a claim and get reimbursed for their HRA. If the participant is eligible and they qualify, again, the key is that they have to qualify for the HRA, PEB will make a monthly contribution, or you might refer to it as an allocation to the HRA. And that is the money that the participant can use to get reimbursed for eligible expenses. The participant can use it for their spouse or for themselves for any eligible medical, prescription drug, dental, vision, Medicare Part B premiums, as well as out-of-pocket healthcare expenses. And I have an eligible expense list coming up in just a moment. But the key to note is that PEB does have a running 365-day claim submission deadline for participants to submit claims, and that's from the date that the claim was incurred. So, for example, if a person incurred an expense on January 5th of 2024, and they tried to submit that expense today, even if they have all the right documentation to substantiate the claim, they would be denied because they missed that rolling 12-month deadline. Okay, so that has come up in the past, and that's just something that's important to note. That is a requirement that PEB has in place for the HRA. What's great is that any unused balances are available in future years. However, as you may know, the board did elect back in back in 2021 that we were going to start a $8,000 HRA cap on the available balance. So anybody can accrue more than an $8,000 balance through the year. However, any balances over $8,000 will be reduced to the $8,000 cap on or around May 31st of each year. It takes a little bit of time to get it administratively done. So typically it's within the first week of June that we have the balances updated. but we're reviewing and looking at balances at the end of May to determine who has a money over $8,000 that needs to be adjusted and reduced. So certainly something that retirees want to be aware of. The HRA is designed to reimburse them for eligible expenses. It is not a savings account. There is no beneficiary that is awarded the money if somebody were to pass away. So it's important for retirees to utilize and be reimbursed for eligible expenses as soon as possible, not only because of the cap, but also because of that 12-month rolling deadline. This is a list of some of the eligible expenses. So some of the most common items, this is not an all-inclusive list. The participants can refer to IRS section 213D for a complete list of eligible expenses. So obviously premiums is probably the majority of the types of expenses that we see. So you have Medicare medical premiums, prescription drug, dental, vision. Medicare Part B is big. We encourage people to turn on Medicare Part B premiums as an eligible reimbursement and get those submitted to us. They can do office co-payments, eye exams, dental treatments, deductibles, co-insurance. Other types of expenses would be contact lenses, hearing aids, lab fees, oral surgery, wheelchairs, x-rays. The list is pretty large. But this just gives you an idea of the types of expenses that people can submit for reimbursement with the appropriate supporting documentation.
It looks like Chris froze.
Looks like his slide is still up. Madam Chair, you can hear me okay, right?
Yes, I can hear you.
Okay, just making sure you still have connection.
Okay, we'll give him rejoin. And if not, then there we go.
Oh, here he comes. Chris, are you there? You're on
I
mute.
am. I'm
There you
sorry.
are.
I don't know what happened. Did I don't know when I lost you all. I'm so sorry.
You were on slide 24.
Okay, so it just happened. Okay, my apologies.
Thank you.
I don't know what happened. Let me share my screen again. I apologize. Okay, can you see my screen again?
Yes, we can.
Okay, great. Thank you again. So let me scroll back one more page. Okay. So did you hear me go through the expenses did I moved on to the other slide yet?
You were just finishing up the expenses, moving on to the next slide.
Okay, thank you, Leslie.
Sure.
Again, Chris Garcia for the record. So as I believe I was mentioning that there's just a large number of different types of eligible expenses. You can see just, again, some of the common ones here. So I'm going to move on to the next slide, but if there are any other questions about eligible expenses, I'll take some questions at the end, of course. How the HRA works. So again, participants will pay for the eligible expense. For an incurred eligible expense, they'll pay out of pocket for it, whether it's a premium or some sort of out-of-pocket expense, like a prescription drug. They're going to submit that reimbursement request either through the mobile app, through the website, or through the mail. And then we're going to review that claim and that reimbursement request and the supporting documentation that's provided with it, and we'll make a determination. If the claim is approved, we will reimburse the participant up to their available balance in their account, depending on how much the claim is for. And then if the claim is denied, we will send out what's called an explanation of unpaid expense to the participant, advising them that the claim has been denied and why it was denied. And typically it has to do with the supporting documentation, or perhaps the expense is determined to be an ineligible expense, such as maybe cosmetic surgery. Those that would not typically be considered an eligible expense. But once the determination is made on the claim, the participant is either notified by receiving a reimbursement, or if there was a portion of the claim that was denied or the full denial, there'll be a notification as to why. We have different ways to help retirees automate their HRA as much as possible. One way that we do that is through what's called automatic premium reimbursement. And this is where we've worked with the different carriers that we have to receive files from them for the different premiums that participants are paying for their coverage. And then we can take those files and the data through those files, and we can load those premiums as claims against the HRA. And the vast majority of claims that we receive are going to be premium claims. And so if a participant is paying out of pocket, say for a Medigap plan, and they turn on the automatic premium reimbursement functionality, if we have it available on that plan, we have it available on about 93% of all the plans that we have on our platform. If they turn that functionality on, instead of the participant having to submit claims on their own, we just wait for that file to come in from the different carrier, and we load that premium information that we receive through the file against the HRA, and we will reimburse the participant accordingly. So the participant just needs to turn on the functionality when they have the plan, and then they would only need to make a change if they choose a new plan at a later time. They would want to turn that, see if that functionality is available in that new plan, and turn it on. Ideally, we would want the person to have direct deposit set up so we can automate as much as we can. So they turn on the automatic reimbursement with the plan that they've enrolled in. The participant only does that the one time. They get the file over on a regular basis each month. We load that premium as a claim, and then we send a participant a direct deposit for their claim reimbursement. That would be the ideal situation. That's the best way to automate their reimbursements for their plan as much as possible. If they don't set up direct deposit, they would just get a check. It just adds a little bit more time for them to receive the reimbursement. So direct deposit usually takes 2 to 3 days, whereas a check might take 7 to 10 days to receive in the mail. We do have HRA assistance available for your Nevada PEB retirees. Obviously, we have our regular toll-free number that participants can call to get assistance. That's available Monday through Friday from 5 a.m. to 4 p.m. Pacific time. But and if they call, they can get help with that number, their available balance and eligible expenses, and check on the status of a claim. They can turn on automatic reimbursement, et cetera, through speaking through a regular customer service representative. However, if a participant does have an escalation and that has not been able to be resolved after they've called our regular customer service center, they can seek additional assistance, and they can set up an appointment with an HRA specialist by calling the 844-266-1395 number. That number is manned by 2 of our specialists from our HRA team, Sandra Rose and Michael Rosenberg. And they will assist participants and try to help engage with them as much as possible to help resolve their issue, especially if it's something that has been escalated. And you'll notice that when I'll talk a little bit more when we talk about, well, let me take a step back. I mentioned previously that we do the retiree meetings. We also have the specialists come to PEB in Carson City, and they'll be available to help retirees if they have questions related to their HRA. And Sandra Rose and Michael Rosenberg are 2 of the different folks who might travel to PEB to be there in person. Another person that from our service center who might attend is Stacy Nelson. She used to be the primary HRA specialist for PEB. So she will also come in person to assist retirees if they need assistance with their HRA and they have some sort of challenges, whether it's submitting claims or, something with a denied claim, anything like that. Those specialists are great resources and experts to help resolve. We have our website is available so participants can sign in. and set up and automate as much as they can online. They can set up direct deposit. They can go paperless if they want to be eco-friendly. They can do that where they don't receive anything through the mail. It's all done online or through email, and obviously submit reimbursement request. So once they get online, this slide gives you an idea of what's available, what shows up on their account. It'll show like the available balance information, and historical balances that they might have from prior years that they could still utilize with new claims. As I mentioned earlier, the mobile app is the newest tool that we have available to retirees to utilize. The mobile app is something that's available through iOS, so that's through Apple Store or through the Google Play Store for on Android. It is a way that they can check their reimbursement status, check available balances. They can submit their new reimbursement request directly through the phone. They can just take a picture of their supporting documentation. They'll enter in the claim information and they upload it right to their account online. It's a great tool to utilize. Obviously, we encourage new utilization. It's currently the lowest number of claims are coming through the mobile app, but we are seeing some small growth there over time as more and more people become aware that the app is available. When we look at the HRA, just to kind of give you an idea of volume of the HRA accounts that we're managing and how much we're paying out through the HRA administration platform. In 2024, we paid out $33,364,000 worth of claims. In 2023, it was around the same number, $33,124,000 in claims. So a lot of activity going on when it comes to claims being reimbursed to participants for the PEB HRA. At the end of 2024, we had 13,733 accounts. Of those, 1,187 of them had no reimbursements at the end of the year. So there are some people that are not utilizing their HRA or have not utilized their HRA. I'm not sure why. We do try to educate them as much as possible. So we have talked to PEB in the past about maybe doing some additional outreach to those individuals, but we do send out balance reminders to participants twice a year, once in the spring, once in the fall, to help remind them of their balances if they haven't had any payments in the last 90 days. So hopefully those individuals who are not taking any action will ultimately decide to go ahead and submit claims so that they can utilize their account. And then we do see at the end of the year a large number of retirees reduce their account to zero. And so they're using up all their funding every month. So we had over 8,000 people do that at the end of 2024, which is great. But they do get new money each month, right? So long as they stay qualified in that plan. Direct deposit, I can't stress this enough. I encourage as many people to sign up for a direct deposit as possible. It's so much easier to receive that direct deposit reimbursement than waiting for a check. Waiting for a check could lead to a check getting lost or stolen, or you could be a retiree who puts a check away planning to cash it and it sits in a drawer for 2 years, and when you find it, the check's no longer good, and then you have to request a new check. We don't want that to happen, so we do encourage people to set up direct deposit. And the great news is that PEB already has good utilization for direct deposit for your retiree population. You've got about 76% of the total number of accounts have set up direct deposit at the end of 2024, which is great. Some other clients of ours have like 40% or 30%. So with the length of time that PEB's been with us, I think we've done a great job of trying to get as many people as possible to turn on direct deposit. And then we look at the funding activity itself. So this gives you an idea of the claims by source and how people or what types of claims people are submitting, what the channel is. So I mentioned auto reimbursement before for that's the premium claims, and that's where we automate the process with those different carriers. Last year we had over 400,000 claims come through auto reimbursement. Then we have what's called paper claims, which would be somebody mailing in a claim or fax. And I will mention that fax is no longer an option as of 2025, but it was available last year. So somebody sending in a quote unquote paper claim could be doing it through the mail or through fax. So that was about 26,000 claims. Doing it online is 27,000 online claims. And then mobile app, again, mobile app is the smallest percentage, and just over 12,000 claims coming in through the mobile app. So last year, for 2024, we had 475,000 total claims that we received and processed, right? So even if the claim is denied, someone had to take time to review it and process it. Obviously, the automated claims, there's nothing that needs to be done there. We encourage automation. It helps our processors decrease the volume of claims that they have to review. But certainly people are going to send in manual claims, whether it's for out-of-pocket expenses or a premium that isn't able to be set up on automatic reimbursement. We have those other channels available for those claims. And that's the end of the information that I have. Oops, sorry guys. So I'll go ahead and take questions if anybody has any questions.
Go ahead, Ms. Kelly.
I'm sorry, I'm the only one.
No, you're good.
Michelle Kelly for the record. Thank you for this presentation. It's long, but I found all the information very valuable. So thank you. I really like that automatic premium reimbursement that you talked about. Do you do that for Medicare Part B?
So we do. It is available for Medicare Part B in certain situations. So the person has to be enrolled through us in a Medicare medical plan. So if somebody has that TRICARE exception that I mentioned earlier, they're not going to be enrolled through us in a Medicare medical plan. So they would not be able to turn on the auto reimbursement for Medicare Part B. But if they are enrolled through us in a Medicare medical plan, they can turn on auto reimbursement for Medicare Part B, because we know that if they're enrolled in a Medicare medical plan, that means they have Medicare Part A and Part B. That means they're paying Part B premiums. And so we can reimburse them up to the standard Medicare Part B premium for the year. If somebody is getting charged more than the standard, then they do have to submit documentation, but we can still help automate that and set that up as a recurring claim.
And sorry, just to follow up. So that, I guess that would be the same for if they're charged extra for Part D.
Correct.
Yeah. Okay. Thank you. And then just a question based off of, we heard during public comment from a retiree who lives in Carson City, who uses the Carson Tahoe Hospital, who I guess have sent out a letter to some of our retirees saying that they're canceling their participation with some of the Advantage plans. And I wonder if you could, if you know about that, do they inform aggregators such as yourself, and or what PEB could do about it to better support our employees? Because I think Carson Tahoe seems to be playing hardball with a lot. I'm sorry, I should have been clear. Carson Tahoe, the participant said, is recommending some Advantage plans that don't appear to be on your network.
Yep. And Chris Garcia, again, for the record, that is a great question. So we have heard from retirees as well as from PEB regarding the situation in the Carson Tahoe area. There has been a request that has been submitted to our internal carrier relations team to look at adding a carrier called Prominence Health to our network. So that has to go through some vetting, of course, and there's a process to add a new carrier to our platform. So that is something that we are exploring. But we have had a member of our customer service team who works specifically with PEB, who's received numerous calls and had several conversations with PEB retirees in regards to adding and looking at the opportunity to add some additional carriers to our platform in that area. So I can't commit to anything right now, but it is something that we are certainly exploring based off of the information that we've received.
Wonderful. Thank you. And thank you, PEB staff.
Okay, any further questions? Okay, thank you, Mr. Garcia. I will close agenda item number 10 and move on to agenda item number 11. Diabetes Pilot Program presentation by Chris Syverson, Nevada Health Partners, for information and discussion. Please go ahead. Thank you.
Hi, thank you, Joy. Thank you. My name is Chris Syverson. I'm the CEO of Nevada Business Group on Health and Nevada Health Partners. I want to thank you for the opportunity to present today, and Madam Chair, the PEB board and staff for your patience. I will try to make our presentation brief, but give you the information that you need and allow you to ask questions at the end. First, I'm going to share my screen. Okay, can everyone see that?
Yes, we can. Thank you.
Perfect, thank you. About a year and a half ago, Nevada Business Group on Health came to PEB and talked about a pilot program that we wanted to present for PEB members and their families. And we were granted, oops, sorry, not changing my slide. I wanted to just give you a brief update of where we are to date and the results that we've been seeing. Just a reminder, Nevada Business Group on Health is actually 2 organizations, and we work with employers mostly in the north, but we are branching out and working with employers statewide on clinical issues, data management, and on direct contracting. As far as the diabetes goes, there are 2 programs. There's the National Diabetes Program, which is a year-long program for people who have been diagnosed with type 2 diagnosed with prediabetes, type 2 prediabetes. A year is a long commitment, and so one of the things that we have looked at is are people staying with the program? I'm happy to say that we've had really good results, and we'll get to those in just a little bit. The National DPP is an evidence-based lifestyle program. It's a year long. Sessions are weekly for 6 months and then monthly for 6 months. That's a mouthful. And we're geared towards having employees and participants make real lifestyle changes. They meet with a trained lifestyle coach and a small group of people who are also making lifestyle changes. And it's proven to cut participants' risk in developing type 2 diabetes by 50%. So if you can stick with it, it's a great program. I've invited several of our partners onto the call today, and I'll have them introduce themselves as well. One of the things that we've been so excited about has been the response that we've received from PEB employees. It's been really overwhelming. Again, the National DPP is about eating healthy, exercising, managing stress, navigating challenges, setting goals, diet and exercise, and staying motivated. Again, a year long is a long time, but if they can make it through, the results are really great. There are different delivery methods, and we've been fortunate to work with our partners. We do a lot of them as virtual sessions, and it's been especially helpful when we're working with people from rural areas or people who can't make it to a specific site. There are other groups, however, that want to meet every Saturday, or they have a different cohort group that just wants to meet in person. And our partners have been very good at designing those programs and developing around participants' needs. What happens is we have sent mailers, direct mailers to potential participants, and they then meet with our providers and they say, well, these are the days that are good for me, or I prefer virtual. And then our partners develop a program around what the participant needs are. I do believe we have one Spanish class, Spanish speaking class also that's going to be offered as well. The second part of the program is what we call DSMES, which is Diabetes Self-Management and Education and Support Programs. A DSMES is for those people who have already been diagnosed as a type 2 diabetic. And so it's to help those people to learn how to manage that condition. Now, this program is a 6-week program. So as you can imagine, we have much better follow through with the DSMES program. I actually had the opportunity to attend one of these with my husband. I wanted to see, one, what the program was about, but secondly, as a person who cooks for someone who has type 2 diabetes or pre-diabetes, I could also understand and hear what they're hearing, because oftentimes it's the family that needs the support. That's also one of the reasons why we send our mailers to the participants' home. Why is this program important? When we first came to PEB, we had about 3,500 people that had been diagnosed with type 2 diabetes or pre-diabetes. And in addition, the CDC statistics show that 8 out of 10 adults have pre-diabetes and don't even know it. So this is a big, big problem out there. We received a grant from the state of Nevada, which is a sub-grant from the CDC. And we are able to bring this program to employers at no cost. The grant has been able to pay for the training and the education materials and the flyers and all of that out of our grant budget. So the ultimate goal is to have programs like PEB possibly cover this as a paid benefit down the road, meaning that an employee, it would be considered in your benefit plan. We target self-insured employers because they honestly have the most flexibility in plan design. But through this program, we preserve the confidentiality, we protect all HIPAA data, and the reporting is only at group level, which you'll see. And I think PEB would agree there's been very little additional workload on the agency to have this program. I'd like to first introduce one of our partners, Sanford Center for Aging, which is part of the UNR School of Medicine. Hannah, are you on?
Yes, I'm here.
So Hannah, if you would introduce yourself and your program.
All right. Yes. My name is Hannah Linden. I'm the director of the Health and Wellness programs at the Sanford Center. As Chris said, we're part of the School of Medicine. We're an aging services organization within the School of Medicine. And our mission is to enhance the quality of life and well-being among elders through education, translational research, and community outreach. As evidenced by working with everyone here and the employees, we don't only work with older adults, but we do a lot of work with chronic disease self-management and prevention for different age groups as well. So we offer the diabetes self-management program and the diabetes prevention program, along with a number of other programs. We're fully grant funded. So we've been offering diabetes self-management for over 10 years. We do that virtually, and we do it in person as well in the Reno-Sparks area. And I think this is still all right. We have about 10 active facilitators. We have some peer leaders, some staff trained. We offer that program in English and Spanish. And we've been offering diabetes prevention program for about 5 years. And we are a recognized site, so we've been successful in having good outcomes in that program. We offer most of our diabetes prevention program sessions online, and especially with this partnership, we get a lot of people who are working during the day, but they're able to take their hour lunch break to join the diabetes prevention program from work, or they go to their car or something like that. So that's been really successful. And we have 5 lifestyle coaches. And again, we are offering this in English and in Spanish. Yeah, I think that's everything I was planning on saying. So thank you for having that slide for me, Chris.
Thank you. Jemima, are you on?
Hi, Chris, I'm on.
Thank you.
All right. Good afternoon, everyone. Thank you, Chris, for inviting me on this call. We are Nevada Health Partners partner down here in the South in Las Vegas, Nevada. I am a health educator and program coordinator for Dignity Health St. Rose Dominican's Community Health Department. Our vision is a healthier future for all, inspired by faith, driven by innovation, and powered by our humanity. Although we are a faith-based hospital system, we do serve all folks, all walks of life, and we don't turn anyone away. We have 7 locations throughout our valley in the Las Vegas and Henderson areas. And we have 3 main hospital campuses and 7 neighborhood hospitals. Next slide, please, Chris. Thank you. And like Hannah mentioned, whatever they have to offer up in UNR, we are offering similar services down here in the South as well. We also provide diabetes self-management programs. We have local in-person classes within the Las Vegas and Henderson Valley. Through this grant and partnership with Chris, most of our classes have been online and are offered in person when needed, depending on the participants that are reaching out to our programs. We offer virtual classes that will open to anybody statewide. So let's say if participants aren't able to join any of Hannah's class offerings, they're free to join ours as well. Currently within Dignity Health St. Rose, we have 9 active facilitators for diabetes self-management programs. And although most of our classes have been offered in English, we can offer them in Spanish as well if needed. And our organization down here in the South offers 2 master trainers who then train other facilitators of the program. When it comes to diabetes prevention, we offer in-person classes and we can offer them online if needed. Much like Hannah, we are also a fully recognized site for in-person and distance learning with the CDC. We are fully accredited. We have 6 active lifestyle coaches down here in the South. All of our classes have been in English, but we can offer them in Spanish as needed. And our organization houses the only master trainer in the state of Nevada to train other lifestyle coaches that would be interested in facilitating the diabetes prevention program as well. I think that's all that I have to say, Chris. Thank you.
Thank you, Jemima. I also have to say that since we've had this presentation, we have also added a third training opportunity, and that is through Carson Tahoe Health in Carson City. We found that we have a number of employers and potential participants in the southern north, if that makes sense, in the Carson City Gardnerville area. And so Carson Tahoe Health also will be providing programs for us in the future. I won't go over the scope of work. This was our scope of work for year number 1, and I'm happy to say that we completed all of our objectives. We had 7 DPP and 9 DSMP programs held. So we had identified 3,478 as type 2 diabetic or pre-diabetic. The number of individuals expressing an interest in the class was about 198 from PEB, which doesn't sound like a lot, but 198 is actually really good. We had the number enrolled. We estimate PEB to be about 42 members and the DSMP 99 members. And then the number completed, at the time we did this slide originally, we had 42 in process and 66 from PEB in the DSMP program. We actually have updated the numbers since we did this program for staff. The dollars spent by the employer program is 0. The potential savings to the plan, it's been highly documented, and I actually think these numbers are a little aged, but $10,000 is about what an employer can save if they prevent someone from having type 2 diabetes, or if they can control it, right? So if we anticipated that 26 participants from the state of Nevada completed, then that would be about $260,000 in savings in claims avoided. Again, I think that that's pretty conservative approach on that. We currently have 73 more registered. If we only manage to keep 25% of those, that would be an additional $180,500 savings. For the DSMP program or DSMES, it's estimated that about $800 to $1,700 a year could be saved in claims. Again, being very conservative, that would be about another $82,500 in year 1 for savings to the PEB plan. That is really all of the information that we had for you today. I did want to give one shout out to Cara, and I'm not going to attempt to say her last name with PEB, but she actually contacted us and wrote an article for the PEB newsletter or for the PERS newsletter. I'm not sure which one, but we saw a huge uptick in people that called and wanted to register for the programs after that article appeared. We were adding programs. I know Hannah was calling me saying, how many programs can I add? Because we had such a good interest in the programs. So thank you for allowing us. We are now in year 2 of our grant year and still going gangbusters. So that concludes my presentation, and I'm available for any questions that you might have.
I just, Michelle Kelly for the record, what does what does the end of the program, the pilot program, look like to you? So how does it end, and what numbers or what data are you going to be able to provide to the PEB board and PEB staff?
A lot of them will be similar to what we have. What we're doing is every year that we've been in this grant, we've been better at tracking our statistics. And one of the things that we're doing this year is really capturing the specific employer that a participant is identified with. So we'll be able to give you the exact numbers of how many PEB people have gone through the program. The ultimate at the end of the program, it's a 5-year grant, would be that PEB would decide to cover DPP and DSMES as a covered benefit within their plan, that they would see it as a program that has provided benefits to the employees. And, we talk about savings and claims. That's kind of my wheelhouse, is dollars and cents, but the simple fact is these people are much healthier. They're leading healthier lives. We are tracking the exercise that they're getting before and after their program completion. So I don't have an end as far as the number of people, but I take everyone as a win.
Absolutely. And I'm sorry, I should have thanked you for offering this program to us and implementing it. As far as the data goes, is there a way that you can pull real data for PEB participants? Are you already pulling real data as opposed to the estimates? So, for example, if someone completes the disease management program, is it possible to feed those participants to PEB so that they can pull real data to see from the baseline if there has been changes? What are we seeing from, as you say, a fiscal perspective in real time?
I think that's a great question, Michelle. What we have found is many of our employers participate in our employer database, meaning that all of their claims go into a data warehouse, if you will. And we've been talking to our employers about, we as the coalition, we're referred to as a coalition, I have access to all of their data as well. And I could go in and I could see what participants registered for the program and what their claims were prior to entering the program, how they progressed through the program, and then what their claims are at the end of the program. So it is possible. I have not talked to the data and claims providers for PEB to see if they can do that. It's very important that we shield the actual participants from the employer, if that makes sense. You'll only get aggregate data, but you could possibly get de-identified data by participant. So that's something that we could pursue with maybe Siegel. I'll have to look at that and talk to PED staff, but I think it's possible, yes.
Right, thank you.
Hey, any further questions? Okay, thank you for your presentations. With that, we will close agenda item number 11 and move on to agenda item number 12, public comment.
One moment, Madam Chair. I will go ahead and get this slide up. We have about 5 attendees in the lobby.
Perfect, thank you.
You're welcome. Joining this Zoom meeting as an attendee is for making public comment only. If you do not wish to make public comment, please leave the meeting so you're not accidentally called upon. Please feel free to watch it via the YouTube live stream on the PEB YouTube channel. The link for the live stream is also located on the agenda on the PEB website. For those who have joined for public comment, your name or the last 4 digits of your phone number will be announced. You have been advised you have been unmuted. Please slowly state and spell your name for the record and then proceed with your comments. Debbie, please slowly state and spell your name for the record if you wish to make public comment. Dyer, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Hui Wang, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Christine. Oh, sorry, we have another one. Or Susan. Susan, you have permission to speak. Please slowly state and spell your name for the record if you wish to make public comment. Last call, if you do wish to make public comment, raise your hand right now. I've called upon you, but you have not responded. Madam Chair, that concludes public comment.
Okay, thank you for that. Seeing no further public comment, we will close agenda item number 12 and we will adjourn.
Thank you.
Everyone.
Thank you, everyone.